Good morning, everybody. Sorry for slight late start for the program today. But today is a very good program and we are starting with two state-of-the-art lectures. One will be by Professor Satyen Tiwari, who is professor and as I call him, head of the two departments of SGPGI. The other one will be by Dr. Rupali Khanna. She is also working in the Department of Cardiology with us and she is additional professor. The chairpersons for this session are Dr. Shailendra Kumar, Dr. Ankit Sahu, Dr. Neeraj Tripathi, and the panelists are Dr. Navneet Srivastava, Dr. Ratnesh Kumar. Please come to the dais. Can I request Shantanu you to help Navneet for this session? I would request Dr. Tiwari to.
Sir.
Morning to all, and welcome to the second day of this academic day. In this session, there are two presentations. Will be presented by Professor Satyen Tiwari. He is a professor in the Department of Cardiology, SCPGI. He will present the topic artificial intelligence in practice of cardiovascular medicine.
Good morning, everybody. Thank you, Professor S.K. Agarwal and Professor Shantanu Pandey to organize such a memorable and long-awaited meeting of surgeons. And I'm really thankful that you have given us the opportunity to share on a very important topic. That's the artificial intelligence, how it's being used in, we all know that it's being used in for cyber crime and various industries and all those things. But what is role in cardiovascular medicine? It's a new technology, and what are the barriers of implementing in cardio, not only in cardiology as a whole, in medical sciences, and what can be the possible solutions of being used this technology to best of our availability globally, not only in the urban population, but as well as in the rural populations, which is very important in our South Asian countries. So as we all know that cardiovascular disease is globally affects more than 500 million people worldwide due to substandard lifestyle, which led to a growing burden of non-communicable chronic diseases and a risk factor for cardiovascular disease. So to manage all those things, the World Heart Federation has recently in one of his global meeting has said that health system today face a fundamental challenges in delivering the optimal care. How one should provide at least optimal care, not only to the small countries, underdeveloped countries, but as well as to the urban and more so in the rural populations. What are the constraints? What are the barriers in their healthcare workforce? And to manage, you have to provide the quality, but then quality has a cost. So what are the financing availability and whether this technology can be affordable for use in cardiovascular medicine and how to deliver? That's a big challenge. as I said, digital health technology, such as electronic decisions, support tools, telemonitoring, remote monitoring, as we have seen in few of the centers in the country during COVID time, or mobile health apps have the potential to help address health system challenges, which limit the achievement of optimal and various challenges in the health system. So digital health intervention is a tool to reach sustainable, that's the aim, to deliver development targets and reduce premature mortality from the non-communicable diseases by a third by 2030. So that's a big challenge, but yes, people are aiming to achieve that. As we all know that this modern artificial intelligence has evolved from machine learning and deep learning. These are the two different parts, but they are connected. So machine learning is basically enables to improve the task which is being provided. The guidelines are there. The initial data is available. And the deep learning involves the algorithm development based on the vast input and how to achieve the output, how to achieve the maximal use of this technology on the convolutional neural network. So these are the two basic fundamentals of the artificial intelligence, both machine learning as well as deep learning. So in principle, this machine learning, one should understand that what it is, whether it is a unsupervised field subset or supervised. So a specific algorithm is selected and presented with the process data. The data is available, and there should be a training of the data with initial guess at solution. Data is tested and then refined and being used practically. So a training can be supervised or unsupervised depending upon the data available, what are the inputs and what we want to achieve that. So there are various benefits which we can see by the digital health intervention for cardiovascular diseases. One is the empowering the patients and the providers like us, hospitals, doctors. Secondly, to improve the long-term patients' outcomes. What are the results? What are the morbidity and mortality, which we can predict? What are the, one should promote universally. These are the health services coverages. And then finally, to reduce the healthcare cost. That's very important because every technology has a cost, which has a quality. So there are, one should understand what are the barriers, why we should use this artificial intelligence in our practice. So there are fundamental barriers which prevents the implementation and access to the digital health technology globally. So health system governance, that's a problem. The health issues are there. Patients and technological factors can prevent the implementation of this technology. So this can cause inequity in access to the digital technology and its potential benefits. So we will not expect too much of benefit initial. In initial, various trials have shown there are not much benefit, but it is an essential to acknowledge. One should understand that not all this technology to date have positivity impact outcomes. So the aim of World Heart, as I said earlier, the World Heart Federation has a roadmap is to provide implementation frameworks, first of all, for local adaptation for prevention, detection, and early treatment strategy for cardiovascular diseases. And this World Heart Federation roadmap for digital health in cardiology, basic aim is to provide recommendation for overcoming all these problems. So as I said, there are several digital health interventions which have shown potential for cardiovascular management. So there are various text message providers, mobile health apps, telehealth, consultation, wearable devices, and electronic decision system. For example, if we are in our MICU, doctor is available, and there is a cross-reference from the other departments, and the person, the nursing staff is not available to that department. So if patient has a chest pain, for example, so he has a wearable device to attach to his monitor, So the chest pain is there. The patient will tell that I have a chest pain. So somebody has to look. So automatically that device, through that device, the ECG will go to the respective chest pain physician. For example, a cardiologist who is sitting in ICU. So he will see the ECG, he will he will see the blood pressure, the pulse, saturation, everything on that. And then depending upon the diagnosis, he will tell this is the possible, without going physically to that patient, he will understand, make a diagnosis, and the moment he will put it, it automatically tells what is the treatment plan. So that is how this artificial intelligence being used. So as I said, there are various randomized control trial, like text time showed that 4 semi-personalized messages sent automatically on the random time significantly improves the blood pressure, BMI, smoking cessation, physical activity monitoring for each and every individual cardiac patients, and adherence to the dietary guidelines. This HERB digital hypertension randomized control trial of 400 patients from 12 sites in Japan showed that an interactive smartphone app retrieving home blood pressure monitoring data to generate a personalized program for each patient, outpatient, already on hypertensive, already on the drugs, how to monitor its profile. So a person can automatically get into enrollment into this app form, and then these patients being followed by the consulting physicians. So these wearable devices used to support the cardiovascular management, like physical activity, energy expenditure. And it's in 2019, there was a systemic review of 28 randomized control trial of around 4,000 patients. The second is the M-STOP randomized control trial, where demonstrated the home-based wearable continuous ECG monitoring of the patients, outpatients. Patch is successfully identified the atrial fibrillation in such patient. So first time the artificial intelligence being used in early diagnosis of atrial fibrillation and various arrhythmias and blood pressure monitoring. The Apple Heart study, we all know, demonstrated the moderate effectiveness of the Apple Watch in identifying people with atrial fibrillation, lone AF. The expert exercise prescription in everyday practice and rehabilitation training tool is an example of a clinical electronic decision supports tool. So these are the few earlier studies being done 4 or 5 years back. But finally, the European Association of Preventive Cardiology introduced the expert study, which shown there is an interactive decisions which helps in enabling the healthcare professional to compare their exercise prescription to predetermine patient care using an algorithm. The recent prompt heart failure trial, and lastly, AI decision to support tools can aid in interpreting the medical imaging data automatically. So basically, then WHO, after these trials, recommend that the health content, the digital application, and then which helps in enabling environmental consisting of a national strategy. I'm coming to a subsequent slide. Reimbursement policies and a digital infrastructure, how it can be done, because this technology has a high cost. So as I said, this digital platform designed to deliver integrated, comprehensive, and continuous patient care. This Empower Heart works on 2 more principles. One is the technology, another is the task shifting, basically where non-availability of the physicians, both in urban and rural population globally. So this Empower Health System has a capability and various important features like mobile app for healthcare providers and a web-based dashboard server for healthcare administration. This clinical decision support system generates personalized management plan. That is very important, because then it's become a personalized. So every individuals, when using all these devices, you can monitor everything as far as the cardiovascular system is required. So it maintains the longitudinal health records, generalized lifestyle recommendations, ability to work in offline mode, and real-time monitoring. That is the crux of this technology. So these are the barriers which I mentioned in the previous slide. So what are the solutions? How to overcome that? So one is the acceptability and feasibility of this technology. Second is the Empower platform. So the government of India, they started in a smaller state. The Department of Technology started into smaller states in Northeast Tripura and Mizoram, and they adopted successfully the Empower Health, where more than 2 lakhs people have been benefited from this technology for this non-communicable chronic diseases. So the national guidelines was formed and a strategy was planned. Initially, there was a lack of national guidelines, how to use all over the country. So they started in these 2 states earlier. Then at the time of implementation of this Empower Health and no strategy for long term. So there is no long term, how one should go forward from initial planning to these 2 states. So as a result, the government of India recently initiated the Ayushman Bharat Digital Mission, which aims to provide the necessary framework and infrastructures, which we are well aware. At the same time, the WHO adopted the Empower platform to develop the MPAN app for managing cardiac diseases. So there are challenges. The consumer focused on the responsive and primary care integrated web application we call as a Connect. So it is a challenge to integrate the data and communicate with the people. And then how to do an intervention. Intervention means how to work on that data. So that is what the Connect web application being used for decision makings, and then prognosticate the disease further. So there are these are the benefits with the Connect app, where interoperability of the digital health intervention being noticed, and this is integrated with the electronic records, guide the research system. That is very important, because unless you know how this patient will behave, for example, artificial intelligence, for example, just see the retina of a person can predict that this person maybe after down the line 30 years will develop blood pressure. What should be his approximate BMI? What should be his blood pressure? What should be the blood sugar level? So all these risk factors you can predict. So predicting a cardiovascular events is a major challenge globally. For example, in coronary artery disease, we know that these are the plaque and that this ruptures and blocks the artery. But those plaques which are mild, stable, how much time it will take to rupture, it's a challenge. If you can predict that this plaque will rupture down the line after 15 years, so that is what we are looking at, and we have no answer right now. So, and the challenges for the rural population, where the monitoring system is not there, the nursing staff is a challenge, the providers, the consultants are not available. So these are the challenges for us. So probably the artificial intelligence, this technology can be used much better way, and it involves the 3 key pillars like clinical expertise, the coordinating the transmission, and then interventions. What should be the drug composition for that individual patients, and then the cost, which is very important, from where the cost. So all these guidelines the government of India has to look. So what is the solutions? So which work in a low bandwidth. So this technology works with the low bandwidth. So that's a benefit with the being used in the rural population. So that is very important. And this help to achieve scalable and sustainable rural telemedicine programs. As I said earlier in my previous slides, there are barriers, there are solutions to implement digital health intervention based on the WHO model. So I'm not going into the detail of these WHO models. We are well aware how it works. But the problem with these barriers, what is the solutions? The most important is the lack of national guidelines as of now. So what is the solution? So one has to establish the national or regional e-health guidelines and strategy. There are poor involvement of the critical national stakeholders, inclusive the engagement with the policymakers and representative of the patient, practitioners, industry and civil society. There are problems with the legislation, how to make a policy, how to implement it, which is medico-legally correct. And what are the strategy and investments? It is still unclear how to use the proper, how to know the proper costing of this technology, how best we can use it. So it includes a long-term investment strategy as part of the national guidelines regarding artificial intelligence. The other is the intervention which is not adopted to the local context. So should overcome to this problem is to perform a structured and a holistic needs and context assessment before designing and implementing the interventions. Then comes the role of infrastructure. Unless you have infrastructures, you cannot use this technology. And then standards, one has to maintain it. How to interpret all these data. So there is a national and international differences in the data collection, storage, and the definition is definite standards. One should promote collectively definition and data storage formats and emphasize the implementation of open data platforms. So unless we have a data, you cannot feed into these tools, and then one cannot use this technology for cardiovascular problems. And then the health workforce, which is a challenge globally. Manpower is a challenge, training is a challenge. So lack of perceived effectiveness and use of digital health intervention, inclusive technology, design and education of the use. And then come the patient. Sometimes patient needs us at the bedside to talk to them, to listen to them, to overcome their problems. So that is still a challenge for most of us for using this technology. But there are positive side also. There are barriers, there are solutions. So this technology being used very much in arrhythmias, LV dysfunctions. We'll know there is a data. You can use this technology into that and detection of cardiomyopathy with a special focus on tissue imaging, detection of electrolyte imbalance, serum drug levels in a cardiogenic shock patients. We know the levels, what it can be. Then wearable and mobile technology in cardiac rhythm disorders. That is the most important, and initially most of the randomized control trial studies such patients. So these are the few of the places. They are very small segment of patients, but then definitely in such situation, these being successfully is working. In India, is still far behind the developed nations. There are Indian Institute of Science, we all know, contributes the most. Recently, the guidelines for artificial intelligence research-based clinical trials in this process, but there are challenges. Accountability and responsibility for decision-making, clinician-patient relationship at risk, that's the most important. Bias related to developer, patient safety at risk, ethical conundrums may require new trainees. Risk of commercialization is there, always it is there. So to implement the artificial intelligence into clinical practice, one should, data acquisition is a challenge, then interpretation and reporting is a problem. So continuous exposure to new data is important, one should learn it. Finally, the question of how algorithms are practically deployed across institutes and countries remains to be determined. So not only in India, the neighboring countries, underdeveloped countries can connect through this technology very quickly. So one should adopt and understand the data into this technology, and which finally helps in our decision making and patient outcome. So whether algorithms should be individually supplied to the individual institutes or enabled is a challenge. Who should control the data is a challenge. And I'll tell you a few of the examples, like in coronary artery disease. This algorithm can assist with patient safety and improve the diagnostic accuracy during the coronary angiogram. Then also you can see in electrophysiology, these ECG sensors are there, and there is an algorithm inside is being there, which helps in, which is non-invasively and can be easily accessed. And finally, these MRI images can be analyzed right at the patient's by this artificial intelligence very accurately. So if you can see, this diagram depicts the AI ECG as a platform from remote monitoring, where patients can't come to your place. So far left is the multiple form factors have been used to collect the ECG, and then this technology via cellular technology to a cloud for AI processing system can be seen, and the general this, and then you can connect to the patient directly and alert in the event of these abnormalities. This is the one of the other examples where top level where you can see the ECG, and lower where the rhythm and the continuous rhythm monitoring is there. By seeing is you can still see patients of atrial fibrillation which are missed, and still they said where a routine ECG cannot find this arrhythmias. By this technology, you can very accurately connect and tell that these patients may have cardiomyopathy, and this cardiomyopathy may not respond to the drugs because of the fibrosis and irreversible changes. So this technology predicts and tells that this patient will not improve. That's very important. Predicting a cardiovascular events, a post-graft patients, whether that graft will work after 5 years or not, maybe this technology will tell you better. So as I said earlier, if you can use this, you can predict the cardiovascular risk factors, that this can happen in future down the line, in the families, in the siblings, you can very well predict. So, but there are limitations. One should understand that despite the immense promises of the machine learning, a number of considerations have its development and require addressing. Data ownership is a problem. There is currently a lack of well-established quality standard and a centralized for this newer technology. Lastly, the physician's engagement and thoughtful assessment of workflow and implementation are essential for the adaptation of AI tools in clinical practice. So one should be very careful. Attention will be essential to permit AI to improve clinical practice. So there are limitations as of now globally. So to conclude this topic, the digital health intervention is help in cardiovascular disease management, prevention, and empower patient in a more efficient care. There is a need for collective action involving patients, healthcare providers, government machinery, industry people, regulators, and reimbursement authorities and policymakers to identify and help and solve the context-specific barriers. This roadmap provided potential solutions for frequently encountered obstacles, barriers, and find out the solutions. Artificial intelligence can play a critical role in better decision-making, hold promises for the future. The physician and trainees need to be taught how to use this technology to best way in their specialty. And many algorithms will be integrated into devices used by the clinician. So gradually, I feel that maybe down the line, after 5-10 years, this technology will come and we can be used very well. So this is unlikely to replace the physician. That's the most important. You can't replace the physician. Today, somebody WhatsApped me that there is a news going on, a lady is speaking, but it was artificial intelligence created. I have in my WhatsApp. Actually, that lady is not sitting into that center where the news is being telecasted. So by artificial intelligence, you can create Dr. Tiwari speaking right here, but I'm not physically available here. So that is one of the tools, but then you can't connect to your patient and to your audience. So it requires proper testing, validation, and prospective assessment, as well as a compassionate and caring clinician to deploy, apply, interpret his finding to help the human seeking care. Thank you very much.
Very thought-provoking and very contemporary topic you have delivered very well. Are there any questions on the floor? Sure. Yeah, I want all of you to concentrate and listen. In 1986, when I went to Vellore, there was a big banner in the post office written there, nothing will ever replace the post. Nothing will ever replace the post. I don't think I have to say anything else. Look where we have reached today. So this AI, if you say, it has to come, we have to progress, we have to make advances. It's a wonderful topic to the juniors or people who are interested. Wonderful topic. Artificial intelligence should be pursued.
I'm just going to do a small thing.
Sorry, Mike, please.
Recently in UK, attending the British Cardiovascular Society conference, and I realized that NHS has already introduced artificial intelligence-based devices for detection, early detection of atrial fibrillation in their population, especially elderly population. So that's one. And the second is that those of you who are really interested in this topic, NEJM has recently come out with a small supplement on this topic, and that's a very informative article. So those of you who are interested can download it free from the NEJM site and go through it. So that will be good. Thank you.
Which site, go on? Which site?
The NEJM site, New England Development.
So, I have, few questions. Wonderful deliberation. What I can understand, I have very little intelligence about artificial intelligence. So what I have understood is there are two parts of it. One is towards the doctors, one is towards the patient. So one which is you elaborated at the end, which is towards the doctors, which prognosticates, which tells you what may happen. There is very hard-end data for that. So what happens to this intelligence when it is applied to our population with its heterogeneity, and where do we get that data from? If we, what I suppose, if we are getting that data from outside, that may not match. So a very small example, you may be seeing very widely in your practice, 2.5 milligram of Ramiprin. Patient does not tolerate 5 milligrams. I have never given 25 milligram BD of carvedilol. 3.125 has same effect. The ejection fraction goes up. So what happens there? So one end is understood. What happens at the other end? And what efforts are being done from the government or CSI for that matter to address the second issue?
Very important concern, and it's a challenge. It's a challenge for this technology and for all of us to use for a particular patient, whether this drug with such doses being used elsewhere in other countries versus being used in our country in our subset of patients. So one can use this technology, will use the data, their data, and tells you this amount of drug and dose is important for their patients. But maybe our experience, depending upon the data, for example, Indian data is already into this technology, is already being loaded into this technology. And then it tells now your patient may require little lesser dose. For example, statins and other drugs. Probably our subset of patients are much more, does not require at that higher doses which Western population does. So this technology is still, it is a challenge, how it can be best used. And I mean, I have no answer right now.
I have an answer. See, you have to understand that you write a prescription today for 20 milligrams of this tablet, it goes home and he's taking it for 3 months and it comes to you. But here you take 20 milligrams today, tomorrow he's being monitored, he will send it to you. So Satyan will say, no, the 20 milligrams is too much, reduce it to 5.
That is the biggest advantage of it. It is not that you write a prescription, the fellow goes home for 3 months and he's coming back after 3 months, the side effect, oh, this is the problem. No. That is the second part of your answer. That this will, my gut feeling is that it will be it may not be possible for everybody to come under that umbrella. That also I say we'll have difficulties, problems, obstacles, everything. But the fellows who come under it will be monitored much better.
Yeah, Dr. Rupali. Yes, Ketan.
This will make it more personalized medicine. It will be more phenotypic guided rather than giving the standard to everyone. It will be more phenotypic guided and more personalized medicine, like Sir rightly pointed out, his heart rate is suppose 100 and his blood pressure is more than 130, and we know we can increase the beta block. So rather than waiting for 3 months coming back to us, we can immediately say within 7 days we can increase the tablet dose. So it will be a personalized medicine going towards this rather than a blanket treatment.
What I
Thank you, Bolo.
Are sir.
what I again understand of it, we are talking of telemedicine sort of situation. We are not using artificial intelligence as possibly what is conveyed, what I have understood. So other point is, as patient, if we say there are maybe three segments we can divide. One is alerting the patient, telling the patient that you have something wrong, you run, meet somebody. That I think, which sir has already told, that has already come.
Yes. What I am saying, the second part of your question was what the Cardiological Society of India is doing on this technology. Recently, there was a core group of meeting in Calcutta last month, and I am the senior vice president of the society. So what the Cardiological Society of India has done is they are making a project and talking with the Department of Science and Technology to Government of India, and to implement this technology to various states. So initially they have started with the Northeast, and now they are coming with 1 or 2 states like West Bengal and neighboring states, and find it out how best this technology can be used in such a high populous states of the country. As far as the clinical, as a cardiologist, as the cardiac surgeons, our problem, what I see about this technology is if we can use this technology best in predicting the problems, like these patients, what the chances of this patient developing various risk factors down the line after 10 years. So you can start the lifestyle modification much earlier. Now, this is the valves. You did the surgery. You put a graft on after bypass surgery. If you can know that this patient after 1 year, you can predict that down the line after 8 years, 10 years, how this graft will work, how this prosthesis will work. With immediate post-surgical prosthesis have such a gradients, how will this gradient will progress down the line after years? I think that then it's become, if you can predict the outcome, that is the best way you can use this technology. Otherwise, as far as the management part of concern, that definitely it will help. But if you can predict something, like you are here, after how many years you become the director and vice chancellor. So is it possible? Yes.
Fantastic. I think I feel that what you are saying, that is possibly the best way which artificial intelligence can help me. One suggestion for Dr. Hirema. In India, we almost all hospitals have computerized hospital information system, almost all. And we at least give very basic information, which you have been asking for, our database. Just a suggestion, with our permission, hospital permission, put a bug in each system. We are not going to give you any data because we don't have people here to enter data. Manpower is there. That bug would transmit all the data which you require directly to you, and it's like sort of a hacking. But that Sir, he must be in the habit of going to court because he has been sentry for such a long time.
Sir, in fact, I have put already in this my upcoming slides, in the innovations and progress of the ICT. You'll see, and definitely, analysis has become a major role and already it's in place. And already it's in, we are working towards it, how we can implement in the country to I'm already on it, sir.
So we look forward towards the lecture. Thank you very much. Thank you, sir. Thank you.
Thank you, Professor Agarwal and Professor Shantanu Pandey for inviting me. Thank you. Thank you for all of you.
For nice presentation on the artificial intelligence. Now we can understand that artificial intelligence is the field of computer science in which computers perform work that usually require human intelligence and thought models. The second topic is translating evidence into practice with newer drugs in heart failure patients. And it will be presented by Dr. Rupali Khanna. He is additional professor in the Department of Cardiology, CVTS.
Good morning, everyone. First of all, from the outset, I want to thank Professor Agarwal sir and Professor Shantanu Pandey sir for giving this platform. And after the talk of artificial intelligence with such a nice discussion, this will be a little boring topic of drugs. For a surgeon, discussing drugs will be like, I need to be a little more interactive in my talk, I understand. So basically, translating evidence into practice with newer drugs, why we are discussing this. If we see 10 years back or 15 years back, whenever a heart failure patient comes to us, we always used to say the prognosis, what we used to learn at MBBS years, the mean survival is not more than 5 years, 6 years. Because the drugs available to us was like, within 5 to 8 years, the mortality is about 100%. But in past 10 years, we have seen there have been availability of newer drugs, which have really changed the scenario in the management of the heart failure. And heart failure per se is the most common entity, which is one of the most common entity, which is leading to your cardiovascular mortality and morbidity in our patients. So if we see the global burden of the heart failure, it is about the pandemic, which is happening all over the world. About 26 million people are affected and its expenditure of more than $31 billion worldwide. And if we see India, India is not say separate or different from the rest of the world, and we are having an increased risk for development of the heart failure. The predicted, if we see that about there will be rise of 25% if we predict by 2030, the reason which have been said by why this heart failure is being seeing more common, first and foremost, aging of the population. Now the life expectancy has definitely increased. So with age, the heart failure due to your hypertensive heart disease or maybe your CAD, there is more prevalence of these diseases in our population, which is leading to heart failure. There is improved survival after MI. 20 years back, 30 years back, when all drugs and intervention was not available, the hypertensive MI-related mortality was very high. But with presence of your good PCI, good revascularization and surgical backup, we have a survival much better in MI patients. So we know the patients with MI with LV dysfunction, they will come to us again and again with an OPDs. Plus, there is availability of the effective therapy for the prevention of sudden cardiac death in the form of AICDs, which have again led to your survival in these patients, but presenting with heart failure to us. What about the Indian scenario? Can we tell the exact amount of patients which we are going to see in our OPD? There is not very clear data. We don't have, as already said, the digital data or the we don't have a proper surveillance system in our setup. But estimated prevalence by different registries, by Kerala registry, by the Tamil Nadu registry, they have shown that estimated prevalence would be about 10 millions. But the second challenge between Indian population is there are limited resources. We don't have a very big resources of your heart failure clinics, pharmacotherapy, heart transplant program, resuscitation therapy. So the main therapy which remains to us is the drug therapy, which we have to offer to these patients. The difference, if we see that what is the difference of your heart failure in Indian population and compared to the Western population, our patients are more younger in age. They are about compared to 10 years younger. Their ejection fraction is more lower as compared to what we see in the Western population. The mortality is very high, about 30%. And the rehospitalization rate and death post-discharge is just 4 times of what is there in the Western population. So we have to be more vigilant in these patients, and pharmacotherapy should be started in these patients in a very effective way. So because of the availability of the newer drugs in 2022, AACC came up with the guidelines for the newer therapy, and in 2021, ESC came with the guidelines, which emphasizes on the newer drugs which are available for heart failure. So they divided that, okay, heart failure, the target which I'm going to discuss in my talk will be only stage 3 heart failure. That means the patients who are symptomatic and who presented us with heart failure, how to treat these patients with the pharmacotherapy. Stage A and B, basically the predicting the heart failure or the risk of the heart failure, will not be discussed in this talk. So if we see the classification of the heart failure, what is heart failure? It's basically the patient's complaints. It's a clinical signs and symptoms diagnosis. Patient with clinical signs and symptoms of your increased swelling pressure, having breathlessness, along with we find the filling pressure in the form of your biomarkers or the echocardiography features showing that there is a patient is having an increased filling pressure, we diagnose it as heart failure. Depending on the ejection fraction, we divide into 3 categories. One is less than 40%, that is the most common heart failure with reduced ejection fraction, which we see in a population, or it can be a preserved ejection fraction in which the ejection fraction is more than 50%. In the mid-range, we have 41, or with the mildly reduced ejection fraction, 41 to 50%. So the predominantly which we are dealing with this having high mortality is that heart failure with reduced ejection fraction, whenever the ejection fraction is less than 40%. And the drugs which have been in the past 10 years have shown that these patients should be targeted very immediately so that the mortality and morbidity can be decreased. So if we see the pharmacotherapy of the heart failure with reduced ejection fraction, what are the different goals which we have to see in these patients? Where to start? First and foremost, we have to reduce the mortality in these patients. Second is the prevention of the rehospitalization and improving the quality of the life. This should be the target for the patients who are going for the pharmacotherapy. So starting with a case example, my talk will be on the case example that how different drugs can be started in this patient. This is the normal common patient we see in our OPD. Is a 50-year-old gentleman, hypertensive, presented with class 2 to 3 dyspnea for past 6 months. And clinically, we are finding that there is increased filling pressures in the form of LVS3 is there, but chest is clear. ECG was showing poor progression of R wave, but echo was showing LV dilated with global hypokinesia of ejection fraction of 30%. And his NT-proBNP was raised. So we know that depending on seeing his clinical symptoms, his investigations, he follows the category of heart failure with reduced ejection fraction. So what are the treatment drugs which have to be targeted in this patient? So we all know this, we have learned in the MBBS time also, the neurohormonal activation is there in heart failure patients. Depending on this, we know that the sympathetic nervous system is overly active in these patients, leading to your increased epinephrine, renin-angiotensin system is activated, there is vasopressin is activated, heart rate and contractility is also increased. The renin-angiotensin system, when it is activated, it leads to vasoconstriction and blood pressure is increased, sympathetic tone and aldosterone activation is there. Plus, there is natriuretic peptide system is also elevated, leading to your natriuresis, vasopressin, and vasodilatation. So these are the therapy which we have to target in these patients of the heart failure. So if we see the different trials or different drugs which have been there for heart failure, we start with 90s. The first one was the ACE inhibitors in Alapril, which was done, and this showed a significant reduction in the mortality by 16%. There were then again, beta blocker came into the picture. It showed that additional 34% mortality was seen in these patients. Again, the ARBs were evaluated, and there was evaboradine was evaluated, and mineralocorticoid receptor inhibitors evaluated. They all showed that there is 37 to 30% of mortality reduction. But the game changer came in 2014, when they said, despite all these drugs, the additional mortality benefit by ARNI is by 20%. Why this was done? Because this, if you see, the drugs that reduce mortality in heart failure, ACE and ARBs reduce mortality between 10 to 20%. Beta blockers have shown to decrease mortality by 30%, mineralocorticoids receptor by 30%. But still significant mortality happens at 5 years of age. About 50% of the patients die within 5 years of diagnosis of heart failure. So this was a game changer in 2014, a neprilysin inhibitor along with your candesartan, it was started and showed that when these patients were having your neprilysin inhibition, there was increased ANP and BNP levels, which leads to natriuresis. This was the basic mechanism of ARNI, which was stipulated. And the biggest trial which was done was Paradigm Heart Failure trial, which compared not with placebo, with other ACE inhibitor, which was a standard therapy which was prescribed in heart failure patients. And this showed that there was significant reduction in the cardiovascular death and hospitalization in these patients, which was more than 0.004. So additional mortality benefit, about 20%, was seen in these patients when they were prescribed with ARNI as compared to the ACE and ARBs. So this was the game changer. So this guidelines came with recommendation that the patients who are coming with your NYHA class 2, 3 with heart failure risk fraction, instead of ACE and ARB, if they are ARNI should be recommended in these because that gives an additional mortality and morbidity in these patients. So this was again after 2014, various trials were done with on ARNI, depending on the different situations. There was trials which were done on your acute decompensated heart failures. There were trials which were done on preserved ejection fraction, and the trials which showed that patients with heart failure reduced ejection fraction, irrespective of their clinical status, ARNI have shown to decrease the mortality. So this was a trial. There was like paradigm only includes class 2, class 3 patient. What about the patient who comes to us in a MICU and have been sick in acute decompensated heart failure state, and does ARNI will helpful in this case? The Pioneer heart failure trial was done, but the catch was that these patients became stable, then the ARNI was started. So the thing when we have to start these ARNI, first and foremost, the systolic BP should be more than 100 in these cases. The IV diuretic dose should be stable for last 6 hours, and they should not be on inotropic support because this drug has been known to decrease the blood pressure. So once this state is reached, they become relatively stable, then the ARNI was started in these cases. And to the surprise, within 3 months of it, we can increase the clinical benefit of more than 46% reduction in the form of your death, pre-hospitalization, rehospitalization, LVAD, and transplant listing in these cases. So these patients, then again, that means the patients who in acute decompensated heart failure, ARNI should be started as soon as the patient becomes stable in these cases. So this was the Pioneer heart failure trial, which concluded that the drug is well tolerated despite having a low blood pressure, causing low blood pressure in that status. What about the second drug which came in after 2020 was the SGLT2 inhibitor. This started with an anti-diabetic drug, which basically was that it was a glucose receptors which are present in renal kidney, and they causes a glucosuria, thus leading to decrease in blood sugar. But various trials, when they were done, they showed that this drug also causes your decrease in cardiovascular mortality in the form of your decreased hospitalization rate and heart failure about death. So depending on this, then the trials were started on doing SGLT2 inhibitors specifically in heart failure patients. And the possible mechanism which they said that can be caused due to this is, first, there is optimized preload reduction in these cases because of the diuresis. The patient metabolism, cardiac metabolism changes in these cases, and there is decrease in interstitial edema and the improved renal function, which both led to your improvement in the heart failure, death, and hospitalization. This was the basic mechanism, but exact mechanism still not very clear that what is that which decreases the mortality in these cases is still in question of research. So 2 big trials which was conducted was the DAPA heart failure and Emperor reduced trial was done. These both were patients who were NYHA class 2 to 4, and Emperor included more sicker patient as compared to DAPA heart failure trial, and both showed that there is a significant reduction in the death and heart failure hospitalization when these patients were given with your all other 3 drugs. So depending on this, the ACC guideline came up that we have to target now 4 therapies in these cases. One is first your beta blockers should be given, the renin-angiotensin receptors should be given, and your NPS inhibitor, positive inhibitors should be given in the form of ARNI, and SGLT2 inhibitor was given in these patients. So these become like a 4-pillar therapy of heart failure to be started in these patients. The initiate, optimize, and reassess. As we were discussing also that these patients should be optimized with a maximum tolerated dose in these cases, and how frequently these to be tolerated dose should be started depends on the patient clinical situation. So this is a more a personalized medicine, rather saying that every patient will be able to tolerate a 25 milligram BD of carvedilol, which we see in our clinical practice is not possible in our settings. So what is the best time to start the therapy in these cases? First and foremost, once the patient is hospitalized, that is the best monitoring time, or whenever we come to OPD, that's the best time to start this therapy. Should we start it sequentially or should we start it simultaneously is a question. So this was the study that this shows that the planning of when these patients are admitted, if you don't start the 30% readmissions occurs within the first week of discharge, and 60% occurs within the first 2 weeks of discharge. So these therapies should be started as soon as the patient has become tolerant to these therapies. So if we see, this was a trial which was done in strong heart failure, recently published, and they said, okay, let us see, categorize these patients. One, we will start in a sequential manner once they become patient safety, and one we will start in a simultaneously, or the patients will be started. So once this was shown that within 3 months of when you see these patients, the therapy was started, within 3 months, the hospitalization rate and mortality significantly reduced in the patient in when all the 4 drugs were started. So these means that the mechanism of action of all the 4 drugs is different, and these drugs should be started as soon as the patient is able to tolerate these drugs. This was and the trial was, stopped previous to prior to it was neither at point, because within 3 months it was showing that these patients are having a high intensity care, have a possibility of event-free survival, much significant as compared to usual case survival. So it became a class 1 recommendation to give this 4-pillar therapy in our patients who comes to us with a heart failure with reduced ejection fraction with the maximum well-tolerated dose in these cases. So coming back to our example, this patient was heart failure with reduced ejection fraction. He was started on beta blocker. ARNI was given with maximal tolerated dose with SGLT2 inhibitor, with a diuretic and a MRA, which was started in this patient. So what is the course which we can expect in these patients? There are different trajectories. Either the patient will have resolution of his symptoms. That means he will have come back with NYHA class 1. Or he may develop persistent symptom that despite all the treatment, his symptoms are becoming class 2 and class 3 and is still having the same symptom, not much benefit. Or he can be a worsening of heart failure. Despite starting the treatment, the symptoms are increasing and he's going into class 4 failure. So if the class symptoms have resolution of symptoms, we should continue with the same medications with the maximum tolerated dose of all the 4 pillars of therapy. If he's having persistent symptoms, then the diuretic dose should be increased in these patients to the maximum tolerated dose so that they can be able to do their functional capacity. But what about the worsening heart failure? That is a term which has to be very seen in these patients, because we know that the heart failure is not a course which is having us in the plateau course. If we see, once they are diagnosed, after diagnosis, they may remain stable for few months to years. So nobody can predict that till what month or what year they will be okay. But once they start having worsening, this worsening will take only a few months to develop into advanced heart failure and cardiovascular mortality. So we have to target now this worsening heart failure, these patients, and is there any other therapy which can be prescribed in these patients? So now my patient came back within 4 weeks. He said, I am developing increased symptoms. He was in NYHA class 4. So he came into the definition of worsening heart failure. Can we do something else in this patient? So why should we care? We know that the worsening heart failure, if we depend, 1 in 2 patients hospitalized again within 30 days of their worsening heart failure, and the mortality is very high. Despite having all the trials which have shown that we started with your ARNI, we started with your SGLT2, we started with your galactic heart failure, omeprazole, these patients have risk of developing 10 to 15% of increased risk of developing rehospitalization and cardiovascular mortality. And despite these 4 pillars, we need some additional therapy for these patients. So drug which was newer therapy, which was started, the trial was done, was a vericiguat, which gave some hope that if we start these drug in the worsening heart failure patients, we might have a plateau course rather going for a uphill course in these cases. So basically, vericiguat has a SGC stimulator. The mechanism of action, it has been shown that it decreases the inflammation and fibrosis, it causes vasodilatation, and increases the renal blood flow in the patients. So this leads to your decrease afterload in these patients and decrease the LVDP. So this was the trial which was done, a Victoria trial. These patients were basically worsening heart failure patients, which were included. They were patients who have a recent hospitalization or the IV diuretic use. And if you see, these patients were on your mostly triple therapy. About 58% were already taking your ARNI, MRA, and beta blocker. At that time, when this trial was started, SGLT2 inhibitors were not still indicated. And despite that, they found that when they randomized these patients, depending on the placement, vericiguat, there was significant reduction in the cardiovascular mortality and heart failure hospitalization at the end of 2 years. So this came up with the criteria that these patients should be give advice that vericiguat can be given in these patients. So which patient should be given the vericiguat? Should we give it to all the patients coming to our OPD? Still, we do not have the data despite the known mechanism. So if the patients are who have recent hospitalization or on one IV diuretic who have to OPD basis, or patient have a hospitalization within 3 months of your OPD basis, then these patients should be given vericiguat in a cases that can have shown to decrease your recurrent hospitalization. Only thing, when you're starting in hospital this drug, always make sure the eGFR is more than 15 ml and patient IV diuretic should have been stopped at least 24 hours prior to the initiation of the therapy in these cases, and other quadruple therapy that the 4th pillar should not be stopped before starting this patient. Dosing is simple. It's 2.5 milligram OD for 2 weeks. If patient is able to tolerate, increase it to 5 milligram, and the target dose is 10 milligram OD. Hypotension is very rarely seen, but it is a known side effect in these with this vericiguat drug. So depending on this Victoria trial, ACC/AHA came with the guideline recommendation of class 2B in patients who are worsening heart failure. Despite guideline-directed medical therapy, this should be prescribed. So coming back to my case, he was diagnosed with heart failure with reduced ejection fraction with worsening heart failure. So this all the 4 therapies plus vericiguat of 10 milligram OD in increasing dose was added and diuretic was increased. So the patient became stable and was discharged on the same therapy. So if we see in the conclusion, what are the pharmacotherapy? If we see the pillars of pharmacotherapy indication, the first and class 1 recommendation is your beta blocker, SGLT2 inhibitor, MRA, and ACE or ARNI. Prefer ARNI most probably. Then depending on the phenotype tailoring, these patients, suppose this patient's having a hypervolemia despite all these 4 drugs is not able to having still volume overload, a diuretic in the form of your furosemide group should be added in these cases. Vericiguat only if there's a worsening heart failure. Ivabradine is a drug which has been shown with a SHIFT trial that these patients who are having increased heart rate despite maximum tolerated beta blocker, they should be advised ivabradine in this shown the decreased heart failure hospitalization, but the mortality benefit was not seen in these cases. So in summary, the patient if comes to us with establish the diagnosis of heart failure with reduced ejection fraction, start the 4 pillar of therapy, not able to tolerate or still symptomatic, look for your other causes, look for if the patient is having a ejection fraction less than 35% of having LF beta branch, go for device therapy in the form of CRT and ICDs, and still not able to improve, going into stage 3 or advanced heart failure, then this comes over the mechanical circulatory support or cardiac transplant, which is not the part of my topic. So how can we improve this guideline-directed medical therapy in our heart failure patients? And what can be done in settings? First and foremost, heart failure clinics are important because these patients need continuous monitoring, because we have seen if we don't give them that maximum tolerated dose in these cases, they die within 3 months. The mortality increases by 30%. These drugs are not advised. So we need good heart failure clinics and the patient education and the guiding the patient toward the best possible medical device and surgical therapy. We should have a checklist in both our wards and in OPDs that what are the treatment medicines which are being prescribed, and if not prescribed, why not prescribed? Because we always, we all are so overburdened when we write a prescription, we sometimes miss the drugs, we don't give the maximum tolerated drugs. So heart failure patients, if you know that this therapy should be given, have a checklist with us that these drugs have been prescribed to the patient. And nurses training and all that becomes a big criteria for, in these managing these patients. Have more physician education programs. And small top of the artificial intelligence, how can this help in this? Like a mobile phone based reminders. Like these patients, if you can see that these patients can send their blood pressure and their heart rate after 7 days of therapy to their concerned physician, they can easily tell, okay, now increase your dose with this. Because they cannot come up to again. And we have clearly seen in the strong heart failure trial, as soon as you increase give the maximum tolerated dose, the mortality decreases. We cannot wait for 3 months, 6 months in these cases, that next time when you will come, we can increase the dose in these cases. So a follow-up reminder should be there. And telemedicine links to the primary health centers are the thing which might change the scenario of the heart failure management. So in conclusion, heart failure is a comprehensive approach. It requires both the knowledge for the pharmacotherapy, it requires knowledge backup from your surgeon, it requires good device therapies in these cases, and once in advanced heart failure, then we should have a good program for your mechanical circulatory support, and the cardiac transplant team. Thank you.
Thank you very much, fantastic, and a very clear lecture on heart failure, use of heart failure. Any questions from the floor?
Ma'am, is there any role of ARNIs in moderately reduced?
See, moderately reduced ejection fraction is a class 2B ejection because there was a trial which was done in preserved ejection fraction and moderately reduced. They didn't find much significance. So still, it's not a class 1 indication. But if the patient is not able to tolerate is hypertensive, then ARNI can be given in class 2B indication.
So I ask you a question from cardiac surgeon's perspective. We are not bothered if patient blood pressure is 130/40. We have time to send the patient to you, discharge from our side, or write any fancy drug, which you have been telling us. The problem starts when our patient is having a 90 blood pressure or 100 blood pressure. What personally I have observed is they do tolerate beta blockers. That is not an issue. You can write 50 milligram BD, that is not a problem. How to go about that?
So the biggest challenge is systolic blood pressure is starting these drugs. It's like 3 drugs can be easily started in these cases. One is SGLT2 inhibitors. The other is beta blocker, as you rightly said. These drugs can be started. And MRS they usually tolerate if the creatinine clearance is good. The challenge comes with ARNI, especially with systolic blood pressure of less than 90. They usually don't tolerate for us in our setups. And we have to start with a lower dose of 25 milligram, which is not recommended also in the according to the studies, which they say start with 50 milligram. So we usually say that we start with a 25 milligram dose, ask the patient to monitor blood pressure and come with the creatinine and potassium level after 3 days to us. So if there is no rise in creatinine and the blood pressure is able to still maintain above 90, then we can continue the same doses in these cases.
I have again usually seen that if I add 3.125 milligram of carvedilol to them, they do tolerate.
They do tolerate.
So is it the right strategy? Or
Yes.
is there something wrong?
No, that's right strategy. See, beta blocker, usually this carvedilol, if we see, they don't cause much hypotension in these cases. They have a more heart rate control in these cases and vasodilatation. Which is leading to all that increase your survival in these cases. But SGLT2 is considered to be the next statin of what we are used to in cardiology. Like statin started with your anti-inflammatory, anti-proliferative. No, we don't know the mechanism. Same thing is happening in SGLT2. We really don't know the mechanism, but the trials are showing that there is having increased survival and event-free survival in these cases.
So at the moment, cardiac surgeons should stay clear of SGLT2.
So normotensive, why you want to basically heart failure with preserved ejection fraction or heart failure with your mildly reduced or reduced ejection fraction and diabetic. they should be started in cases.
There's a fair amount of documentation which says that it has a positive impact on the heart failure patients.
So I think we should introduce, as far as RV is considered, I have started with my practice, anybody with a low ejection fraction, post bypass surgery. I introduce them, but over a period of time. So initially I said, put them on beta blockers and send them and the diuretics. And then I have, because some patients, lot of patients, not some, have this blood pressure of around 100. So I start introduce an evening dose, forget about even 25 in the night. So then call them after a week and then increase it to 25 twice a day. I don't know what benefit, at least it introduces RV. It has no, basis for starting something like that. But I have seen that over a period of time, these patients do tolerate RVs if introduced. The minute what happens is, we start with 50 milligram, pressure comes down to 80 and it's a knee-jerk reaction and stop. So this patient for lifetime will not receive RV because he himself says, Goli khane ke baad I get giddiness and all those things. So the best thing is to introduce in the night dose because they are sleeping after that. So they won't feel this giddiness. And then put up a morning dose. Increase your evening dose to 50 first and then your morning dose to 50 from 25. So that is what I have started doing it. And I think it's doing fairly good. I mean, this is just evidence-based practice. It's not, has no documentation or anywhere.
I agree,
But
because,
that's how we can try.
and biggest challenge is not a score tablet, we are giving it, that's.
Now, there are certain companies which have come with 25 milligram. The biggest challenge is that because they say that the two drugs don't mix into each other. And we don't know in which part of the tablet.
Which part is
the one drug will be more than the other.
One more. What time do you think that these patients with worsening heart failure should be considered about future therapy and put into the program? Because heart transplant or mechanical circulatory arrest cannot be provided at the spur of the moment in most of the patients. So we need to have a plan to introduce these patients to the heart team where we can plan about future therapies for these patients to decrease the mortality further.
I agree, sir. That's why we need a heart failure clinic in which cardiologist, cardiac surgeon should be there. And sorry, yes.
I have complete.
No, that's what basically.
Other, I have taken because of introduction of armies, the heart transplant list is becoming less.
Less.
There are a lot of patients now who are feeling absolutely fine and are refusing because I had to pull them out of my waiting list. I had registered them for transplant and they said, now I can play volleyball, I can play those, I'm doing all my activity. So now then, do you think really?
I think
it's not justified. Looking at their lifestyle, they are moving around and doing fairly good. The ejection fraction still looks 25, but physiologically they are much better.
Like from,
so it's better that we postpone it.
Like from cardiac surgeon point of view, the transplant for us, the CRT implantation has decreased. What we used to do for a CRT implantation 2 years back, the number of cases have drastically decreased after introduction of your ARNI and SGLT2. So they have really remodeled the heart, one is, and second, the patient become asymptomatic. So these both going hand in hand, CRT implantation and other additional therapy have really decreased after introduction of these ARNI and SGLT2.
Yes, I agree what Dr. Rupali is saying. So definitely the need for all these procedures become lesser and lesser. Secondly, definitely as what you are aiming to is that if in spite of all these patients need repeated hospitalization, then it is a concern for us to make them into the program.
Thank you, sir.
Thank you, ma'am, for my explanation.
Now we will move on to the next session, that is pediatric cardiac surgery. Unfortunately, we only have one lecture for this session because the other two speakers had to cancel their trip because of personal reasons at the last moment. So I would request Dr. Sachin Talwar, Dr. Ankit, Dr. Swati Pathak, Dr. Vikas, Dr. Anil Verma. So we have got 2 persons on the chair. And now I will invite Dr. Siddharth CR to enlighten us on surgical management of tetralogy of Fallot. What, when, and does size matter?
Good morning, respected teachers and dignitaries on the dais and my colleagues. Anyway, I was given it has been a privilege to be invited back to SGPJ to speak about tetralogy of Fallot in front of my teachers. And it's been a humbling experience also to talk about how to do a tetralogy repair in front of the teachers who have already taught you. Anyway, the history of tetralogy Fallot goes a very long way back. It's about 300 years since Mr. Stenson described the anatomy, and we have been doing repair since 80 years, the shunt procedure since 80 years, and the complete repair since past 70 years. And we have also inspired Hollywood to make a movie on it. And still, why do we need to still speak about tetralogy Fallot? Are there any unanswered questions still? I hope so. It is just that is the reason I'm talking. Going back in the history, this is a paper which was presented in 1973. This speaks about the natural history of tetralogy of Fallot. In the paper, they had divided the children who presented with tetralogy of Fallot into various groups depending upon their symptomatology. With group 0, where they had no symptoms, where they behaved like a VSD, and group 4, where they had severe symptoms, who behaved like a tetralogy of Fallot with a pulmonary atresia group. Looking at the other table, where the focus is only on the children who were totally asymptomatic. There were 40 among the total group of 59. And with the time, at the first follow-up, at least by 6 months, nearly half of them had become symptomatic. And with time, obviously, the situation worsened. And even at the end of 1.5 years, there were 5 children who were lost, probably died because of the disease itself. And we can only imagine the condition when the children is already symptomatic at birth, the progress is even more faster. So why does this happen? The underlying pathophysiology of tetralogy of Fallot is there is significant undergrowth of the subpulmonary infundibular chamber. This eventually leads to progressive fibrosis, and there is consequently there is undergrowth of the pulmonary annulus and the arteries. So this is a progressive condition. Fortunately, a lot of studies has been done, and we have come up with guidelines to when to intervene on these children. The Indian guidelines presented through the IAP recommend complete repair for an asymptomatic or a stable or minimally sinus child between 6 to 12 months. Whereas most of the Western literature prefer to do a repair between 3 to 9 months. And we all agree that no repair should be delayed for more than 1 year of age. So what to do? Obviously, there is a lot. The surgical technique has already been refined, and nowadays most of us prefer to do a trans right atrial and a trans pulmonary approach. I will just enumerate the few steps. We try to tackle the VSC and the infundibular stenosis through the transatrial route, the transatrial tricuspid route, where we evaluate and enlarge the pulmonary subvalvular area. And if we find the annulus is small or the valve quality is not good, we make an incision on the main pulmonary artery, look at the valve, release any supravalvular tethering, and do a commissurotomy. We assess the adequacy of the RVOT, which I'll talk about it in the next slide. And we then close the VSD and repair the supravalvular incision, which we have made with a patch. So how do we assess the adequacy of the pulmonary annulus? So we prefer to use a BSA related Z-score diameter values. And the target for us is to achieve a Z-score value of 0. And we sometimes accept a Z-score value of -1 or -2 consider when we are planning to do a valve sparing procedure. We should not use the term valve sparing procedure very loosely. I'm not talking about the procedure where we left one part of the valve thinking that it might provide some amount of competence. A valve sparing procedure should give reasonable amount of competence and have very minimal PR. Nowadays, we shouldn't accept any valve which is regurgitating for more than a moderate degree. And when we find the annulus is truly hypoplastic, we do a transannular incision. And the transannular incision, contradictory to classical teaching, we should not go berserk. We should limit the incision on the right ventricle and spare the infundibulum as possible. The target incision should accommodate the diameter, the required Hagar of the Z-score 0. Considering we are making the assessment in relaxed state, we should usually accommodate for more than 1 millimeter. Again, going back to history, this is a paper from Day2, which was famously known as the Day2 criteria, where they had looked at their repaired patients, 104 among them, and they looked at the post-operative RV peak right ventricular to peak left ventricular pressure ratios, and none of the patient who had a ratio of more than 0.8 survived. So this was a cutoff criteria at that point, and so subsequently, considering the long-term benefits, we have come down. We have understood the good benefit is attained when the post-repair PRV PLV ratio is around 0.5. Nowadays, we try to do an intraoperative echocardiography, and we try to find out the exact points of dynamic and fixed components of obstruction, and we try to relieve all fixed points of obstruction, whether it's at the annulus or the branch pulmonary arteries. And we should also note the degree of the pulmonary regurgitation which is present. Coming to the PR, it is an unavoidable consequence sometimes, and we know this. We already know the long-term complications of the pulmonary regurgitation. It has been said the RV dilatation, which results because of pulmonary regurgitation, predates RV dysfunction and which predates mortality. We initially thought the pulmonary regurgitation in the acute post-operative setting is tolerated well because of the thick RV. But this is also untrue. This is a paper from the Toronto group, which shows where their comparison was done between a transannular patch group and a non-TAP group. We know the children who had underwent a TAP group actually required a longer duration of ventilation and stayed in the ICU for a much longer time. And they also had a severe degree of PR, naturally. So what are the strategies we employ to prevent free PVR? There are a lot of reports which describe the use of monocusp valve, which was usually fashioned by an autologous pericardium or a PTFE membrane. People have also used partial part of the contigra to provide some amount of competence. The monocusp, this is a meta-analysis from 2022, and this is a table showing the duration of ventilation among these patients. Children who underwent TAP with a monocusp had a significantly lesser amount of ventilation period compared to children who underwent TAP without a monocusp. But we know the monocusp only lasts for a few amount of years, and eventually that also will give rise to free PR. So what is our technique at SGRH? We prefer to use a PTFE bileaflet valve, which we create intraoperatively. This technique has been described by Graham Nunn, and we have adapted. We presented our series in 2018, and we know that the operative time increases because it takes time to prepare the valve. But there's significant difference in the ICU stay compared to the child who underwent a valve procedure and a non-valve procedure. And we have been doing this, and our current experience is closer to 100 now. And still we have to come out with long-term results. However, not all patients with TOF are created equal. So what do you do for a child who is less than 3 months of age? So the usual options are a shunt or a repair. So we don't know the optimal management strategy. So the usual points towards a system to pulmonary artery shunt is we usually do it with a sternotomy, or some people try to do it to the thoracotomy. Nowadays, most of the places we do a modified BT shunt, although there are some scenarios where we'll have to do a central shunt because of significantly hypoplastic central pulmonary arteries. The shunt avoids a cardiopulmonary bypass and DSA altogether, and we all know the complications of a shunt. And the STS database, which studied between 2002 to 2007, the hazard function for mortality, the inflection point was the patient weight at 3 kg. But unfortunately, most of our patients come at the weight which is less than 3 kg, and we'll have to do a shunt, so making it a very high risk procedure. So what is the other alternative? So in 1991, the Boston people presented their their early report on neonatal repair. But unfortunately, they had closer to 20% mortality. And when they went back to analyzing the data, they found children who had a Nakata index, children with pulmonary arteries which were of Nakata index less than 150 had the highest risk, and none of them survived. So they rethought the strategy and they came up with other paper in 1999 with closer to 100 patients who were less than 3 months. Now this time they had 3% mortality, but the incidence of transdermal patch in their series were closer to was almost 85%. This data has been validated again subsequently by other centers also. So should we do a routine neonatal repair for all children presenting less than 3 months? So looking at the database, again, it is not universally accepted. The neonatal repairs still account only for 6% of all the TOF repairs which we have still done. So the experience is quite limited to very limited few centers. The argument for neonatal repair is when you do a neonatal repair, the effect of cyanosis on the brain development is usually curtailed. But to most of the centers, when they do a complete repair, they use DHCA, again, the risk of brain development is hampered. This is the database from the STS. And if you look at the risk mortality for the complete repair, just closer to 7.8% in the neonatal group. At the same time, the shunt also has a mortality of 6.2%. It's either one or the other. But waiting beyond just 1 month of age, the risk of mortality reduces to 2.5%. And we all know the best results come between 3 to 6 months or 3 to 12 months. This was a paper which came out in 2019. This was an administrative data set where they compared tetralogy of fallow repairs who underwent a primary repair and a two-stage repair. The red line representing the two-stage repair. After the initial steep fall, at the end of 2 years, only 84% of two-stage patients were alive, whereas on the primary repair, only 77% of the children were alive. Even though we quote a risk of 3% and 3 to 5% most of the papers, the long-term results are not actually good. So we have to understand repair tetralogy is a chronic disease state. And because there is higher incidence of TAP in this age group, there is always an associated complication which follow. So what should be the current strategy? Individualization of treatment should be the rational approach. For any child who is presenting with less than 3 months of age, he is definitely a challenging subset. At least in our practice, the relative indication for a shunt procedure is when we have significantly smaller pulmonary arteries. And if we have got anomalous ILD crossing the RVOT where we cannot do a transdermal patch, and sometimes we do a shunt repair because of other reasons, and child might be having an intraventricular hemorrhage, preventing us to do a bypass procedure. The decision becomes very difficult when we have a threatened isolation of the branch pulmonary artery, where we have to subject a child to pulmonary bypass, cardiopulmonary bypass, and sometimes it is very difficult to manage a child with a shunt circulation rather than a complete repair. So it is always a balance between a surgeon preference and the unit experience. Coming to the last group, the children who present to beyond 1 year, the reason for presentation can be multifactorial. It can be socio-economic for most of the reasons. There is always a natural selection which happens in this age group because we know 25% of the children who are tough don't survive till the first year. Fortunately, most of them who survive have good anatomy and complete repair is usually possible. And the additional challenges are most of them have collaterals which need coil embolization in the preoperative period, or they have profound cyanosis. Sometimes they even present with cerebral abscess or stroke. This is the aim. This was the only paper which I could find from India. The AIMS experience shows 14% of all TOF repairs were done for teenagers and adults. And even among them, 16% required a two-stage repair, and 11% required coil embolization, and 70% still required a transdermal patch. The usual complications are bleeding because of extensive collateral formation and venous engorgement, and pleural effusion because of a very thick RV, which we experience. So what should be the ideal repair strategy? This was presented by Dr. Charles Fraser in one of his innovative commentary. And I think we all should agree that we should always preserve the right ventricular function and be conservative in our transannular incision. And the treatment should always be individualized, and the patient follow-up should be for life. and it has to be, at least we should aim for 100% follow. Thank you.
Very nice talk, sir.
Thank you.
I had a few questions. Sir, regarding the age criteria, sir, it has been written in all the cardiology literature that patient should be taken up at before 1 year of age. Sir, what I have learned in my residency also, sir, usually practice that after 1 year, and the age criteria was 10 kg. But after that, I never started practicing this surgery before 1 year, and the age criteria I take is around 3 months to 1 year. The youngest is 3 months we have operated. And what we have noticed that the mortality, morbidity is much higher in this age group of the patient in my center rather than being operating the patient at 2 to 3 years of age. So, what is your experience? Is that age criteria is right? Or what is the exact age we should take the patient? Or is there any event of any spell in the patient to be considered as an emergency surgery, even if it is managed conservatively?
Very optimum question. So what I would say is any repair, and when we try to come down on the cutoff age, I think it has to come with experience. We shouldn't start off by doing like we are comfortable with doing a child who's like somewhere around 1 year of age, and all of a sudden we don't want to shift to repair who is at 3 months of age. There's a vast difference in perfusion strategy and even the post-operative care. I think the progress has to be very gradual, and I think with time we'll understand the challenges of handling a neonate in the post-operative care. I think with experience it will come.
Okay, I'll tell you what your problem is. See, I know what you're trying to do at the age. It is very difficult to answer. And nobody can answer this. It comes with experience. What the child is presenting with, what are your clinical findings on the child? What are the investigative things that are the investigations that are helping you, and how much experience you have? And then you can go age start reducing to often. It is not one person to give you a solution. I've seen this from families onwards who was doing cardiology initially making big ventriculotomies, and now we do it with 1 centimeter ventriculotomy. I've seen the improvement myself. What you are asking is correct, but nobody has an answer. You have to find the answer yourself.
With a small comment, I go about the cutoff, and what my personal observations are, and what I always been seeing in this center, about the positive growth. They've always propagated the new effects of the. If you talk to the group from Washington by Dr. Jonas, who was initially the chief of Boston Children, now he says that you should do the petrol beyond 6 weeks of age, because by that time the duct has repaired itself. By that time they have been able to go about the duct. Then the stenosis at the left coronary artery side are showing up at that time, and it is easier to correct. You see the knee root, it was initially from Melbourne, and then knee root and just group in the test. They advocate the repair at 6 months of age. The reason for that is that if you increase the age of repair to beyond a native period, then your chances of doing a well sparing of which increases. The younger the patient is, to a unit, then your chances to pass the better. So increasing the age to shifting the age to the older population means that you can develop the problem better. Otherwise, you end up in the transfer of fat, don't to avoid a transfer of fat, you try to go before you end up getting out of it. That is one of the important things. The other thing is the pulmonary artery size. See, pathology patient, it's very difficult to assess the pulmonary artery size. Unless you have a CKN on echo, it's very difficult. So the rough guide to that is separation of the patient. If Dr. Jonas always there. If the patient has a separation of 85%,
And it's very unusual for them to have a science of 55%. But if the saturated is more than 85%, means that the lung is capable of handling that sort of cardiac output. If that is true, the pulmonary arteries are adequate, because the only thing is they are underfilled, they're not set. If you do a primary repair, still able to get a low. The other thing is that if you see many papers, a lot of surgeons, you do not see the PR value. Because these days, the esophageal echo has eliminated the need for the PR value. Because if you need to read many papers, the PR value is one. But in 24 to 48 hours, also because obstruction is damage. But if the transvagal echo does not show an anatomical obstruction, the infundibulum is contracting, then you find that the PRV, initially the heart is very dynamic once you come out in the bypass. So it becomes a very, very process. So that is what I have observed and what I've seen. From the best power very high. And similarly, you know, at the one step up, it used to be the teaching was see the step on between the RA and the side. There were also some managers because at the time of winning from bypass, the FIO2 stands very high. And again, the RV pressure is high. The moment the RV pressure falls in the post ocular, then the saturation can become better. So we really, I think, is very comment on that. So I think these things become very important as far as that. And the other thing which I learned is there of the technology of more difficult than our research. Because and all the others which have to suffer. I have one question for you, and start with
what should we do for a grown-up child or an adolescent who has got a -2 value or maybe slightly less than -2 value at bifurcation? And suppose we take such a child and we are not able to come off from successfully or sustain coming off from child goes back on from after 15 minutes. So what are the strategies of bailout at that point?
What is this -2 at bifurcation you're saying?
The pulmonary artery side at bifurcation. Bifurcation means first branch, right and left.
And what depends on what you're doing. You have a process with echo. Then you know anatomical problem with that. I think that's true. Because maybe the problem is not the anatomical having what you're seeing. Maybe it is something to do with it's using a hypothetical system. Yeah. Most of the time it is
Not a hypothetical. It's not a very hypothetical.
-2 is not going to be trouble. What is actually the manifestation of the trouble is that love and so that is one.
Anatomical obstruction
You don't air in the corridors, you let the heart, you the heart inside and then try to come off. But the tradition always been in out little patch and then so they will come off. I do not think that situation the whole world with -2 is something not for in fact if you
-2 is fine. If it is slightly less than minus, like -2 suppose is 8 millimeters and your artery reads 7 millimeters. Now those 8 and 7 millimeters are given by CT scan. Those values appear in CT scan. And on eyeballing, you know that this artery looks small. This is a grown-up child, say 6 or 8 or 10 years. And you expect you dissect nicely the artery and expect the arteries to grow once you do a total correction. And then you are having problem in coming.
I think the only bailout at that point is to open up the VST, sir. If you are somehow stuck in that situation, I think obviously the RV will fail. And
I don't agree because that total in losses even if they are more than -2 as long as the other pulmonary artery is not a problem.
It should not be a discrete obstruction. That's what if you like. If you are talking about a discrete obstruction, then it should be repaired. But if you have a diffuse scenario, I think any attempted repair will be probably just postponing whatever, making the obstruction much more distal. So I think you shouldn't have operated like that.
Then in the surgical strategy, you walk on a path in the reversible. I made a mistake. Yeah, then your selection criteria has been wrong.
So what do you suggest? This is a child who walks, who is okay. Adolescent. And he is otherwise happy. You can't give him a total correction. So what is the next strategy?
The patient has not been operated.
Not been operated, pre-operated. You know this situation pre-operatively. Z values at the bifurcation of left and right pulmonary artery is 8. The artery is 7 and 9. One side it reads 7, the other side it reads 9. So what do? Are you checking? Saturation is around 70%.
And what is the weight of the patient?
Weight of the patient is like 25 kg.
For 25 kg, 7, 8 years number.
So you would attempt total correction.
You would do a correction in some way every so that you have adequate decompression. So a lot of people have used the adjustable air and so that whatever can be manipulate the size of the electric circle effect. That has been if you're not able to come up back on things, you are telling us the size, but you're not telling us where is the obstruction and the outflow.
He is talking.
There is the size all through is
There is no obstruction, then the pulmonary artery should have grown better. There is some obstruction somewhere, that is why they are not grown.
the obstruction is was at the infundibulum that has been relieved, and that has
But
been.
you're talking pre-op to decide, and now you're going to post-op that already we are stuck. Now make up your mind where you want to talk.
Pre-operatively, see, you have to make a decision pre-operatively, and that will have corollary on post-operative also. So if pre-operatively you are getting these branches, and obviously he is a technology, he is.
Stop or
We are talking of a situation where we do not want to end up in this problem. Decision, if suppose decision galat ho gaya, you realize that I would not have done a total.
then you understand the VSD.
Demonstrate the VSD.
You just do an outside ventricular outflow palliative patch, that's what. No, the simple, if you know the YAMO bypass, then it's.
Take the patient back to ICU.
That is the only option.
Then you understand the VSD, later on, if you pulmonary goes, then you close.
Then you go with
That's the tradition. What's your time? You got to get.
Fenestrate the VSD. If you are going to have an RV systolic dysfunction because of high afterload, we should fenestrate the VSD.
Are we still doing
See that as long as you finish the VSD, then you will not going to have after.
No, before we fenestrate.
Next to the VSD after go and then you close the agent device.
Why not the ASD?
Or the better thing to do in such patients is instead of doing a stent, you just put a transfer patch. So the transfer patch is a safer option as compared to stent, and it will lead to growth of the pulmonary artery faster than a stent. At 8 years of age, doing a systemic pulmonary artery will not lead to pulmonary artery, just distend the pulmonary. So and its growth is not going to be uniform. So just limited mental property and put ROD patch. And once the pulmonary artery grows, after the 6 months, then you go and patch. That is a simple thing. I've done it many times, small outflow patch, and let the pulmonary artery grow. That is much better than my shunt. Come back to it. Yeah. The shunt is very unreliable. So the shunt is something which can lead to distortion when at 8 years the pulmonary artery don't expect them to distance away. So growth is unreliable. Put small value to patch, let the pulmonary artery go back in after 6 months to a year and then do a correction. And do not relieve stenosis. Just divide the infundibulum muscle. And this and just put a and people do it without clamping the aorta. Yeah, without clamping the aorta. As long as the heart is, do not put the completely empty the heart, make a small ventricular thing, and if you have a defibrillator, just you put it down.
Simply to build it up and make it. It's very,
So then you do not necessarily.
if you are scared of the air, go to separation. Just to build it up and do a small vent. No restriction, nothing. A small vent. Don't even need a side pneumonia. Deep pneumonia, whatever it is, just simply do small vent. Put an optical patch, small optical patch, so that there is no, it doesn't bulge and lead to a lot of energy. And just put a patch on, just completely.
And alternatively, probably nowadays we can even do a shunt in the RVOT. Stent in the RVOT, sorry.
That is a horrible idea, because that is, to land is the moment you have to take out the shunt.
You are with the cardiologist or your.
The surgeon.
See, I have seen, I have myself.
It becomes a very nasty.
Because of the difficult attempts at taking out the shunt. I have lost patients who are trying to pulling the stents and then got in a lot of trouble.
Actually, one thing we have noticed is when we take out the stent, no longer it is like sub 1 centimeter incision on the RVOT.
Because stent is sometimes, it has its indication. In a very, very small child, a very sick child, it will put a stent. Otherwise, an older child, like what Dr. Chandra is saying, I do not think there is
In those cases, better spend the PD.
Yeah.
In case you're so worried about the outflow, the previous time, the previous DC.
Time, I think. In a patient with a top with a multiple VSD. How can we help? Should we take up patient? There is no option other than that. Treatment option. You have to take out immediately. There's multi like nothing like a permanent plan for a top. There's nothing like there. Some detergent is contraindicated. I do not think what is the proposal? What is the alternative? What is the alternative? Then you go to the cardiologist and see what can help out with. You repair and then you have the with the device or in the surgery. It is all not going to tolerate it. Not even a 2 minute. It is not unless and until you're doing the absolute spin top, which is more of VLBCS. VLBCS no escape. But a patient whose saturation is low, who has a typical top, he will not tolerate this. That's a good your experience multiple VLB top.
You don't want to do again. We want to wait for a certain age to repair. Obviously, most of the VST is closed.
Not going to close off. Not going to close off. Because as long as you have big subaortic VSD, if you shunting right to left, you have a good release of the right ventral pressure. You will never close the VSD. See, the multiple VSD close only if you have a severe machine to the RU2 by getting a bad. No. See, a patient who has a top, the RU is how will you expect? You are not going to close. The multiple ways will never close one country at all. They will never close. They will never close. If you think that they're going to close, we follow, it is not going to happen. It's just not going to happen. Then your only option is to get a cardiologist or
And most of the time they are not picked up because RVLB questions are same. So this sometimes comes as a surprise to you.
Yeah, post-op becomes the moment you reach the RV pressure is going to start coming at
I was just talking about the pre-operative scenarios. If you know at the.
If you have small VSD and you think the photo, so the moment you decompress the RV by taking care of the RVT, they will say, I'm also there. So then you are in trouble. So this cardiologist then the only option. There comes the cardiologist rather than a plea of. I think the more further question we could look for more. Thank you very much.
Thank you, sir.
Thank you for an interesting session on tetralogy of fellow. Now we come to the last session of the CME, and that is the mixed bag. I would request Dr. Jigar Shah, Dr. Yashpal Singh, Dr. Pankaj Srivastava, Dr. Varna Verma, Dr. Sanjeev Kumar. And I would request sir, as soon as comes back, to also come on the dais, because he will enlighten us much more from there. And now I would request Dr. Shantanu Pandey to start his talk on, because that was the talk which we missed yesterday because of the lack of time. That is minimal invasive cardiac surgery, present and future.
Dr. Shantanu Pandey, no introduction, the crowd. So, this area pioneer of invasive cardiac surgery, and sure we will enter with the different aspects of it, which your students can follow.
Good morning. First, I would like to congratulate Siddharth for such a beautiful lecture and on a difficult topic, which I am still confused, as you would have realized from my questions. But very well taken. Thank you very much for that. So now I'll be talking about minimal invasive cardiac surgery, present and future. I will try to base my topic on the evidence, a bit of scientific data. And then, as usual, the topic is like for all of us to decide what the present scenario is and what the future should be. So this is an interesting, this was an interesting, actually, the line which I have taken from this article, this was a review article, and it says recent development in minimal invasive cardiac surgery, evolution or revolution. So it actually, if we think about this, it is much more of revolution when it started, and revolution usually do not last very long. So and they have some purpose, and if revolution doesn't have a purpose, then it is futile. So if we talk of why this revolution started, we actually started competing with cardiologists, and we started thinking of newer and better ideas of making our product more visible and better seen to the public and to the cardiologist also. However, what we have been talking about, the benefits of MICS, considering it to be a revolution, is it creates less pain, which is a false narrative. It creates more pain than stenotomy. It has less blood transfusion. That is true. Fewer wound infection. Yes. Less pulmonary complications, plus minus. Faster recovery. Yes. Except for pain. Yes. And better cosmetic results. Definitely. So are these the traditional benefits of MICS, what we are talking of? Are we just looking at them, or are we looking at broader or better outcomes with minimal invasive cardiac surgery? So if we slightly take, I should say, support of evidence, evidence has been gathering in favor of minimal invasive cardiac surgery, which possibly either we are not very well aware of, or we do not actually scientifically mix our revolution with this evidence. So this is 1999 paper, which says there is complement activation. And this complement activation is much more when we do stenotomy. We know this. Most of us know this. So this, when there is an inflammatory scenario which is created by doing stenotomy, which brings a cytokine storm in the body, and when you are comparing it with a non-stenotomy incisions or small thoracotomy incisions, the complement activation is much less. The other evidence is cardiopulmonary bypass. So if we use sternotomy and we do thoracotomy and we use cardiopulmonary bypass, so what happens? What is the difference in inflammation in these groups? So this is an experimental study, but this has very nicely demonstrated that 30 minutes of bypass, 60 minutes of bypass actually is in favor of thoracotomy and bypass. Complement activation is less and inflammation is less as compared to group which had sternotomy. Now this advantage is lost if bypass is long. Unfortunately, at this point of time, we are doing minimal invasive surgery where we take slightly more time because minimal invasive cardiac surgery is yet developing. That is what I feel. Then the influence of inflammation, as we have already discussed, and coagulation. What happens to the coagulation profile? We talked that there is less bleeding after minimal invasive surgery. So this evidence in humans, they have shown that there is less coagulation problems and less inflammation in thoracotomy incisions than sternotomy incision, and that probably is the reason why we are seeing less pulmonary complications, lesser blood loss in patients when we do minimal invasive surgery. Now I will take one thing at a time. Minimal invasive cardiac surgery is a big topic. So we do valve surgeries for this. We have coronary surgeries in this conundrum. So let us start from aortic valve surgery. And this is interesting analysis from Lamella's group, which is a very strong proponent of median mini sternotomy AVRs. Now, interestingly, if we see at this point of time, much more mitral valves are repaired through minimal invasive than aortic valves. We'll see what the evidence of speaks, either it's in favor of mitral valve or an aortic valve later. But why aortic valve is done less is because there are issues in aortic valve. We were discussing yesterday, should we go by upper hemisternotomy? Should we go by rat incision? So there are considerations. So there are basically challenges for the surgeon, whether he'll be able to see the valve nicely, would be able to excise the valve nicely. The issues of giving cardioplegia to the right coronary ostium, the issue of taking sutures on right coronary cusp. So those are issues which still dog us, and we are doing less of minimal invasive aortic valve. And if we see these 11 articles which they have analyzed, which have reported minimal invasive aortic valve surgery through either rat incision or a hemisternotomy, we would realize that out of this study, out of these 11, 8 are favoring minimal invasive cardiac surgery. And this is favoring in sense that was less mortality. Only 2 studies are favoring sternotomy. So that is the hardest point which is available to us in analyzing results of 2 operations. So if we again see this meta-analysis from Leipzig group, they have shown clearly that in unmatched population, the mortality with minimal invasive AVR was less and significantly less. And when they were matched, still this significantly improved outcome with minimal invasive AVR was there. And to our irony, we are using less of minimal invasive AVRs. So we have to think about this. Actually, AVR is the operation. Considering this evidence, we should be doing minimal invasive. When we talk of minimal invasive mitral valve replacement or repairs, it's about 25% in USA, and almost half of the repairs or replacement in Germany is done through minimal invasive. So why is there more acceptance of minimal invasive MVRs with us? Because the incision is very clear. You gain size on the fourth intercostal space, you will see the left atrium right in front of you. The mitral valve is facing the surgeon. When the surgeon is still, when the patient is tilted about 30° from supine position, and it can be done with regular instrument also. You need not have very fancy instruments for this. So there is much more acceptance of minimal invasive MVR, and it has appeared as class 2B indication in ISMICS, minimal invasive society criterias. So if we see the meta-analysis in favor or disfavor of mitral valve, what we realize that meta-analysis has shown that the mitral valves, minimal invasive mitral valve surgery do also have favor if we consider mortality as the endpoint. So it favors minimal invasive MVR. But when we take high quality studies, then there is no difference between minimal invasive MVR or stenotomy mortality. So actually this minimal invasive MVR is actually not adding to advantage in mortality, though it may be adding advantage, giving us advantage of less infections. Obviously, there is no sternal infection. It can be easily done. It can be a template for learning minimal invasive approaches, and it definitely causes less bleeding. But minimal invasive mitral valve surgery has a definite role if there is a redo tricuspid valve replacement or repair you have to do. Minimal invasive is good. If you have flowing internal mammary arteries where a bypass grafting was done and you want to do a mitral valve repair or replacement, then minimal invasive approach is good. Obviously, in redo cases, in obesity cases, in high cases with prohibitive pulmonary dysfunction. Now, this is dichotomy. We are talking that minimal invasive mitral valve surgery is not helping us if we are taking primary cases. But when we are talking of advantages of minimal invasive mitral valve surgery, we are talking of all high-risk situations. So this needs to be ironed out. And this just shows that actually, though we may not be able to do minimal invasive mitral valve surgery in almost all cases, though we should. This is the reason why we should be considering these facts and should be surging ahead doing minimal invasive mitral valve surgeries also. So these are what we have already discussed, benefit of minimal invasive valve surgery. Then from minimal invasive valve surgery, we'll move to the benefits are lesser trauma, what we have discussed, avoidance of stenotomy we have discussed. Now, can we avoid cardiopulmonary bypass and manipulation of aorta? We do not touch aorta at all. So this becomes an ideal minimal invasive surgery. We are not touching aorta. We are not going on cardiopulmonary bypass. We are not doing stenotomy, and we are causing less trauma. And that is only available at this point of time with minimal invasive coronary artery bypass grafting, which is less practiced, but is the best operation which we can give, offer to the patient. I'll not go into details of this because it is much more technical, but what I can tell you from the results which we have been pursuing at Sanjay Gandhi PGI, we compared minimal invasive multivessel total arterial revascularization with stenotomy, multivessel total arterial revascularization, all-cause mortality was similar. When we compare it with our patients, which we received one internal mammary artery to LAD and other veins, there was significant difference in mortality at follow-up of 10 years. So I think this speaks a lot volume about why minimal invasive CABG should be pursued. Now, if we talk about future of CABG, future of minimal invasive cardiac surgery, what are we looking for now? When we are already doing minimal invasive mitral valve, we are already performing minimal invasive aortic valve replacements. What more do we want? So for it to become more standardized, for it to be accepted by more surgeons, the vision should be better. The control of instrument inside the chest cavity should be better. The incision should be least, and the patient should be discharged very early. And if I talk of these things, we all think about robot. So that is the future, that it gives you a fantastic vision. It gives you a fantastic control on instruments. The incision is minimal and the patient can be discharged just in one day. As well, he would have got a stenting done with cardiologist or a valve procedure done in cardiology. Now, I would love to share my view on minimal invasive valve surgery. So if we want to basically bring everything to one incision, suppose you give one incision and you are able to do a mitral valve, tricuspid valve, aortic valve, or a double valve, then this approach of going through axilla, I have found that this can be a single approach which can help us in performing all the valve surgeries. The incision is given in axilla and the entry is done through the fourth space. Obviously, we went all the left atriums in mitral valves as well as aortic valves. This incision is made and anterior axillary line in fifth intercostal space, from which a cannula can be put. This is after cardiopulmonary bypass, femoral. You can see the aorta nicely. The aorta is there. You have to use long instrument. It makes it much easier. So what we can see here is this is the left atrium, which is very clearly seen right in front of us. This is aorta almost in front of us. The only problem in axillary incision is the lungs of our patients are bad. They won't go down just by disconnecting the patient from ventilator. So the incision should be right at the pectoral muscle. So actually it is, I would say, anterior axillary line. It should be just abutting at the anterior axillary line. This is the cannula is which is being put. The other thing which I would suggest, this is the left atrial retractor which is being put through a separate incision anteriorly. I use Felling instrument, so this is one of the Felling's retractor. But now there are at least three companies which are making left atrial retractors, and those can be used. I'll just go forward. I'm just trying to show you that this single incision can actually give us access to almost all the valves. So this field is dry, much better. This is planning to put a clamp. It is important to lift the aorta in the transverse sinus and see whether the clamp is not going to injure the left atrial appendage. The mitral valve is seen right in front of us. So that is the beauty of this incision. I have measured the distance between the thoracic wall internally and the pericardium. That distance in 10 patients was around, mean was around 10 centimeters. So if we take pericardial stay incisions and pull the pericardium up by at least 3 centimeters, the distance between the skin incision and the heart would be about 6 centimeters. And that gives much more confidence to the surgeon. It appears that axilla is quite away from the heart, but in actual it is not. And you can see the mitral valve is so clearly seen right in front of us. We just need some long instrument to be comfortable. What I would suggest is we must start using prefabricated knots. That is core knot. That will make the whole experience much more enjoyable. The other interesting part in mitral valve surgery is you can put the stool up and like a bar stool, and you would be sitting on the stool like you sit on the bar, and you can do the operation sitting. So that is the fantastic, that is quite relaxing. Your back is straight and you're sitting on the stool and you are enjoying the operation. And when you come off, use of carbon dioxide is important. And when you come off, the important thing would be you come off from pump, you stop when you are happy that on TOE there is no air inside the heart, go on full pump, take out the cardioplegia cannula, you stitch the hole there, and then you come off pump. Before you release clamp, put a pacing wire, because it becomes very difficult to put a pacing wire once you have released the aortic clamp. And this, I think this single technique, this single incision can give us access to almost all the valves, and we would be repairing much more valves using minimal invasive technique. Transesophageal echocardiography is the mainstay which guides the cannulation and which guides the whole operation till the finish of this spectacle. Thank you.
Demonstration of engineering value and discussing the pros and cons. Because this is a field which is upcoming, and if you have to compete with the capital procedure, we have to do it. And any tips of putting cross clamp?
When
you have solved it.
yes, in cross clamp, when we are putting cross clamp, the only concern is we should not be injuring the left atrial appendage. So the easiest way is you take one suction, put the suction in transverse sinus, slightly lift the aorta up. You can very clearly see through the incision in axilla, the left atrial appendage. You put your Chitwood cross clamp, apply the cross clamp, clear of that appendage, and that is done. It is very easy to do that. Same incision, with a separate incision, not through the same incision. The only thing which comes out of the incision is your cardioplegia cannula.
Yeah, another thing of what you mentioned is, in fact, not in hard way of using the appendage and going for open sternum. What we do is after that, we could take a long, once we drill the cord, we tie a thread to that and put it in that trans screw, I say, wet basket. That takes care of that, and we can apply for much more safely also. That's another option we have. We need to invent and reinvent as we are learning, and that is another option what we do.
Now the manager is going to be another devil's advocate.
Yeah, sure.
I think the goal of this topic is misnomer. It's not minimal invasive. It is minimal incision
Excess.
access or minimal access surgeries. Because the rest of the surgery just remains the same. I think what invasion is basically a pump and non-pump, especially in coronary surgeries. That's all it is all about. As long as you're doing beating heart surgeries, I think that's minimally invasive. Other than that, I think most of the results which have come up, the data which comes up, it comes up with a biased way. Because we are literally want to prove that minimal invasive, by bringing in minimal invasive or minimal incisions, we are competing with the other forum where they are doing it non-invasive, especially the cardiologists. So I think the most important part of it
it has its own role, like I mean, one surgery, but coronary surgeries, we all understand as cardiac surgeons, we cannot guarantee a complete revascularization by minimal invasive. However, we may say that I have been talking to people, I myself do minimal invasive, but it has a limited role. If a patient needs fair amount of revascularization, say that every artery needs to be revascularized, I think we need to take it very clearly that we go in for an open sternotomy rather than going for minimal invasive. So we still are not there that we can produce a similar type of result with what we can achieve with open heart, with the sternotomy. So that's the biggest shortcoming of our procedure. But then it's a market driven. Nowadays, patients ask if you have a robot, you will see that they will ask for a robotic surgery, then because the fear of scar is already being itched into every human mind. They just don't want any incision, they don't want any cut of their body. And we are being driven by that. But if you want to give a complete treatment, I think this is still a far away from to achieve by minimal invasive.
Very well said, sir. That is why initial 5 slides were on the basic research, which promises that minimal invasive can be better. But the biggest problem right now, what we are facing in minimal invasive is obviously long cross clamp time and long cardioplegia time. So as we have seen in that article, if your cardiopulmonary bypass time increases beyond 60 minutes, the advantage of thoracotomy incision is lost. And that is basically minimal invasive surgery has to progress more to bring this time shorter. And how would it progress? By use of technology. So if we are throwing 7 knots on 12 sutures, so you are wasting so much of time. And it's not very easy using the knot pusher, giving those knots. You have to use xylocaine jelly to basically lubricate that braided suture to push it inside every time and have a very secure knotting. So it is the time that we should spend slightly more, and we shift towards core knots. Each core knot takes not more than 30 seconds to put. So in 5 minutes of time, you would have completed the whole thing. The other thing for aortic valve is we should start using more of sutureless valves, because they are closer to the TAVI valves. There is almost no stent. That is why they give you unidigit gradient even when we implant a small valve. So even at root of 19, there is nothing. It's just a very thin nitinol frame. On that, those leaflets are hanging. So it's very easy to, it's very conducive to the patient. And the whole operation can be finished in 15 minutes. And it is giving good long-term results also. So we should be adapting to new technology if we want to bring this time down. So that is, your points are very well taken. That is much of concern. There is huge bias in selecting patients. I have been doing minimal invasive CABG. I propagate that, but I accept in this audience that I have a huge bias in selecting those patients. We do all patients through sternotomies, but we cherry pick patient towards robotic surgery or this. So, and about inadequate revascularization, it always will be. Because when we are choosing a patient, when we know that this posterior descending is small, I'm anyway not going to graft this posterior descending, convert it to 2 vessel and take it for robotic CABG. So the bias has started from there. So there can never be total revascularization with minimal invasive. That is very true.
Sir, any specialty to DA during mitral cases? You use blood dissection or how you completely DA? Yeah, it is always DA guided.
TE has to be there. That has to tell you that the process is complete. Use carbon dioxide installation in the whole thoracic cavity. What I do is slightly put carbon dioxide inside the left atrium also before taking last few stitches. Always put vent. Always put vent in all minimal invasive surgeries. I would say even in ASDs, put a vent. Because we are not going to see whether the left ventricle is going distending or not. And even if you know it is distending and not beating, you can't do anything.
So went to the incision or from the RSP?
Right superior pulmonary vein. So it comes from this fifth intercostal space incision where your chest drain will come out from. So you put a vent from there and just guide it through the right superior pulmonary vein. It stays out of your operating area, but it is the best tool of de-airing. So what I started doing before embarking into minimal invasive valve surgery, I started venting all my patients, and I stopped touching heart after cross clamp was released. So you get out of this habit of squeezing the heart. So just heart is not beating, let it be there and keep watching that it should not distend. That is the only thing. It will start beating after some time, but it should not distend. And that will prepare you for going to minimal invasive surgery once you put the clamp on.
And sir, for aortic wall, minimal invasive, do you always prefer transaxillary or second or interval?
Second, I would say that I have dream of going through transaxillary, but the easiest is going through median hemistenotomy. So for improving your confidence, go through hemistenotomy. We must realize that in aorta, through axilla, we are going to cut the aorta sideways. We are not going to cut the aorta the conventional way we know. So we are going to cut the aorta sideways. So that has to be kept in mind.
Sir, one last question for second anterior thoracotomy. Do you always ligate RIMA or you safeguarded RIMA?
If it is injured, you ligate, otherwise let it be. Yeah. Adult. Yes.
Okay, so if you're dealing with a patient with severe pulmonary irritation, that is,
Tetralogy.
Yeah.
Yeah.
A lot of people make a small thoracotomy with this. No need to dissect nothing. Just expose the pulmonary artery, make the pulmonary abdomen, it works very well. And plus, you know, it eliminates the risk of the sternotomy, after post correction, severe fear, big ventricle, right ventricle, adherent to the heart, dilatation, lot of problems. If they can the pulmonary artery, access the pulmonary artery, and just the second thing is now you will be performing Glenn analysis. To make a small upper thoracotomy, see the right pulmonary artery and go Glenn.
Wow.
So it eliminates the the content procedure. You do not have to do a sternotomy, you don't have to dissect, you don't have to avoid the risk of reoperation completely. Like a physician, small thoracotomy.
Yeah.
I'm sure you're going to become more and more increase the application more and more. I have seen one supracardiac lead it's very tough.
Yeah.
The type 1A lead and in fact the 1B also, in which a strong recording is made. See, the type 1 2 the like a ASD. The pulmonary vein is coming to the chamber is going to be SCCRG. So steroidism go and do. I've also seen a supracardiac interval. So often the supracardiac can be done by Tucker approach, which is the superior approach, which you dissect the chamber between the SCC and the dome of the right atrium. So simply see the common chamber from there and cut across the breast of the right atrium. Do an anastomosis between the vertical vein, the chamber, and close the vein. So that is also something possible.
Yeah.
You explore that.
Yeah.
Not small, not possible in small children, but as you go up over 5 years, it's possible. Thank you.
So that is what the future holds for us. So 10 years.
Dedicated, there has to be a center base where they are doing minimal invasive. Unfortunately, the learning curve is very high.
Yes.
The learning curve is so much that all of us have to go through sternotomy. So and understand cardiac surgery. Our training has to be primarily with sternotomy. So you can't completely wipe out this thing and move on to minimal invasive as of today.
Very true.
That maybe with technology coming in, robotic things, we will be trained. Like as I was trained for beating heart surgery, taking out mammaries that's skeletonized. So that itself was a mind block, though you have to remove them as first as medical. First you have to do as a beating heart, as an open heart surgery, as on pump and arrested heart. So that moved and now we can be trained directly. So I think it's just question of time with
Yeah.
better technology coming in.
Yes, you have to do at least 2 a week, minimum.
You have to keep
Minimum.
on-
So it has to run as a program, and ideal would be do a 1 every day, and within 2-3 years you would be cracking.
One OT is gone.
1 OT is gone. Yes, very true.
One point, it's been a while we have been doing minimal invasive labs. What I have done recently, at times our incision at the groin is not bigger than this incision. Actually the same size. So I have started using Proglide.
Proglide, yeah.
I use 2 Proglides. And that costs around 16,000 for 1 Proglide. And it works very well for aortic cannula side. For vein, you don't have to put anything. You just compress
Yes,
it. It works absolutely fine. And there is practically no incision there because at times it gets infected and it's really troublesome. It gives a lot of trouble for 2 weeks. You have to.
I would say one to.
Yeah, I'm planning to do that. As soon as I get experience with that, I will probably have 1 only.
Because the second prototype always costs 2 months separate. And then it will end up.
Agreed.
Later on,
Agreed.
for a lot.
I have that mind, but then I just need to gain more confidence in that. So I'll start doing it.
At least you want your patients to come back again.
Sir, any minimum weight criteria we follow for a minimal invasive ASD closure? Because in smaller babies, the femoral artery and vein size will be small. So it is very difficult to go for a.
I would suggest that there is no weight criteria. If you are planning a femoral bypass, how I have basically got confident with it is before the patient is draped, request your anesthesiologist to show you femoral artery and vein, or do it yourself, ultrasound, measure the size of femoral artery and vein, plan the size of cannula which you can insert, discuss it with your perfusionist, whether he will be able to empty the heart completely using those cannulas or not. If everything is yes, you can use femoral approach. If you are not comfortable, then you can even do direct arterial cannulation and biatrial cannulation, bicable cannulation through that incision itself. But then the incision size should slightly go up. What we have created discrimination in minimal invasive surgery, it will cross 5. So if it crosses 5 or 6, we stop calling it as minimal invasive. So that is kind of rider you put in your brain. But still it can be done through right thoracotomy. Okay.
If there is no question, go for the next speaker. The management of acute aortic dissection chronic pains by Dr. Dila from Mumbai. Dila is a very known name in our CVTS. He has been joint secretary and treasurer for a long time. And he is going to be organizing something for the local conference. And he regularly doing many invasive surgeries of TAP, CVD and replacements. So this is a very pertinent topic, acute aortic dissection. Today we are talking there is no patient to die without operation.
So videos नहीं आएंगे मेरे
United
Zoom चल जाएगा सर,
Zoom
से
us.
I think this will come with this. Thank you very much for giving me this opportunity, Dr. Agarwal and team. I think it's a pleasure to be here. I wish we had more residents here. The whole thing was made with an idea that I'm talking to residents. And it's a very open topic. I mean, the management of aortic dissection, acute aortic dissection, I think it can take me a couple of hours to finish and talk in detail. I'm just going to escape to pick up the pertinent points, and I'll just try to put it up as much as possible. Now, we can't forget when we are talking about aortic surgeries, we can't forget the stalwarts like Dept, Coley, and Crawford. So these are the people who were the daredevils of cardiac surgery, and they have been doing something which was unthought of once upon a time. Like touching an aorta and doing aortic surgery, it was a surgical exercise once upon a time where we knew that we are only going to bring out a patient with no blood flow in it. Means to be putting it nicely, that a dead patient. So I remember one of the story which was told to one of my senior surgeon, when I was sitting, and he said, "Okay, once I went into KM hospital to inquire about a very close relative of mine to be operated there for aortic aneurysm, and one of the resident who is now retired and a very big name came out and started with a smirky smile, and he told him, 'Do you think any patient walks home from here with this type of surgery?' So he said, I was aghast, I was shocked. My relative is inside, he's still not come out, and he's talking already about the death of this patient. So that was the fact, actually. That is how we always had a surgical exercise. And till date, in centers which are not used to aortic surgeries, create a lot of fear, instill a lot of fear about the post-operative results of this. And but then, as we are moving into 21st century and newer technology coming in, a lot of safe ways of performing these surgeries have been already established. Safe protocols have been put into place. Now more and more people are venturing into aortic surgeries. In a center like my own, which is not a very big center, when I started, I knew that is going to have a lot of challenges. There were a lot of things I had to bring it together. It is still a very morbid procedure, not only for the patient, for the surgeons also. It needs large size bladder, because we have been going to standing there for hours together and still not able to, express in front of people that I need to go and come back. But then, as I said, we have come a long way. So it is very nice of way putting it up. It's not about making the right choices. It's about making a choice and making it right. That's very, very pertinent thing. I'm going to start with the negative way. We all still know that the overall in-hospital mortality of aortic dissection is nearly 25%. And it can go more beyond this in centers which are not regularly doing this type of surgeries. These are from centers which are very well known for aortic surgeries, and still their mortality in unstable group goes up to 31%, and in stable patient up to 16.7%. That itself shows that how morbid these procedures are. And if you look at the 1 and 3 year survival for the patients treated is phenomenal. With surgery is 96.1% and 90.5%, the 3 year survival rate. That means we can give a better life. We can really pull out a patient from the deathbed in such cases. And without surgery, it can just drop down to 68% in 3 years' time. And most of them actually, as of today, also don't see the end of the month. Now, quickly going through this normal classification, the Stanford classification and the Dept classification, type 1, type 2, type 3A and 3B, which is ascending aorta involving
the type 1 going up to right up to the bifurcation, and the type B, which is just the descending aorta beyond the left subclavian. So this is how we need to know the classification and before we venture into these surgeries. The newer nomenclatures, because we are coming into now TVAR, so we need to know the landing zones. So now the near classification SVC aortic dissection nomenclature, which says that zone 0, 1, 2, 3, 4. If you are venturing into wire procedures, you are going to venture into stent, then we need to know the aorta as different zones. Now, just a quick way how it will look. This is the type A dissections and where the tear normally is. So the more you know about this disease, the more it is easier for you, more familiar you have to become with the disease, and it's much easier to operate on these patients. And this you'll realize and every time you open an aorta, there's always a surprise. And then if you know things very clearly, then you can really estimate at what level this whole surgery is going to go to. So we have seen that ascending aorta tear is the most common in 90%. The arch tear is in just in 5%, and the descending aorta tears are less than 5%. Here is the type B dissections. Here the tear is beyond what we see as beyond the left subclavian going down, and then abdominal is just in 1%. And descending tear just is mostly beyond the left subclavian is in 85% patients. Classification from timing point of view, the hyperacute time is within 24 hours. Acute is from the first day to 14 days, which is an inflammatory phase, very, very friable tissue. And subacute is from 15 to 90 days, the 3 months, where the inflammatory process is already started resolving, but the intimal flap is there and it remains still pliable. And now from here onwards, the mortality rate starts curving into a plateau. So this is actually a safe time, but most of the patients do not give so much of time to get into subacute phase. And chronic is like aortic model after 90 days or after 3 months, where already aortic remodeling has started and the intimal flap has already become fibrotic, making the surgeon's life much, much better. So there was one patient recently which was admitted and was supposed to be shifted, but then the surgeon kept on saying that he will try to see if he can pull it down into a subacute and a chronic phase, and unfortunately the patient never made it. That's the irony of this, that we just don't know which way a patient will be going once we decide that we are going to wait, but because it can just become bad any moment, any time of the day. Just before coming here, I had a patient. Very unfortunately, I put it on my surgical group also. This patient came in and I had no CT scan or nothing. He traveled 300 kilometers, remember, 300 kilometers with this aortic dissection, diagnosed at the periphery by just a plain HRCT and as dissection. Somehow he managed, reach my hospital. There was no CT scan and I did not want to take this patient because I burned my fingers earlier. And I sent this patient to my CT scan department, got a CT. By the time he came back to my ICU, he arrested and died. So that's how dramatic these patients can be. We just don't know at what level. I felt bad about that patient traveled 300 kilometers to come to my place and could not come to my table even. So now there are another way of classifying this as uncomplicated aortic dissections, where there is no rupture, no malperfusion, and there are no high-risk features. So what are the high-risk features? Anything having a refractory hypertension, not getting control with at least 3 medications, refractory pain, effusion, bloody effusion on CT scan, diameter more than 40 millimeters, radiographic evidence of malperfusion, where SMA must have occluded or renal arteries must have occluded, entry tears on lesser curvature. Remember, these are more dangerous to operate. They are very high risk than the outer curvature tears. And initial false lumen more than 22 millimeters and readmissions of the patient. And complicated are the patients which have ruptured and malperfused. So what is the whole aim about the investigations? It is very, very important. There was a debate on our group itself that you should put up a T, take the patient in and start operating. We all try to become heroic in such cases, but at the end of the day, when after the long 12 hours and 14 hours of surgery, we bring up a dead patient, the
the first brunt is how to put it up to a patient's relative that we have worked the whole day and we couldn't salvage this patient, and it is demoralizing itself. So it is important that we just know the complete anatomy, the complete pathology of this patient before we take this patient on table. Important. Very few occasions when the patient has ruptured and there is a CPR needed and you have rushed the patient and then, they have already lost the battle in such cases, then we agree ourselves mentally also that it is a lost patient. And if he still makes out of it, it's something good that we have done for this patient. So ascending aorta involved or not, it's important to know site of proximal tear, extent of dissections, diameter of the aorta, involvement of coronary osteas, arch vessels, visceral arteries, pericardial effusion, left ventricular function, and valve function, etc., like aortic regurgitation. These are very important to know, and that is what should be confirmed before we take this patient on table. So the basic algorithm in management of type A aortic dissection is first clinical suspicion. And believe me now, earlier when I came back here, there was hardly any aortic dissection coming to me. But recently we have been seeing that they have been picked up in smallest possible center. Severe back pain, they are now diagnosing because we have been going and talking to people, trying to tell them what exactly they should look for when they are. So that clinical suspicion has to be grown into the lower possible cadre, like right up to the GPs, to physicians, to main CT scan people or echocardiographer. So that is not only clinical suspicion at our level, clinical suspicion has to be infused into our local doctors. As soon as the patient comes, important that you have access, quickly cross-match blood, because very difficult to get all sort of blood, because this is a surgery where you have to be ready with your blood bank has to be drained out. That's one thing. When a dissection patient comes in, the first phone call goes to the blood bank. You have to confirm, shift CT, get a CT aortogram and confirm the diagnosis, get the patient OT readies, and you can just start moving fast. Everybody has to know their job here. So before that, you should remember that give an anti-impulsive therapy where we have to get the pressures down. We don't want these dissections to move further, become more aggressive, more involving and become high risk or complicated by involving the peripheral vessels, the abdominal vessels, or renal arteries. So we have to control the pressure. So anti-impulsive therapy is very important. Don't forget, because we surgeons, as one of them said, that I don't understand anything about the thing. Here we have to be a physician, you have to be a ward boy, you have to be an anesthetist, you have to be everything, because it's all about planning. So what are we going to? Our targets are mean arterial pressure, between 60 to 70, don't let it go. The reason for it going up is pain. That's the reason why blood pressure shoots up. So first of all, most important drug for you is morphine. Eliminate the pain, get beta blockers, get the heart rate down, because it's very important for propagating of dissections. And if you have SNP, use in SNPs, or in refractory hypertension, enalaprils. So this is what every patient with requiring type A surgical therapy of type A dissections. It's an emergency surgery to avoid tamponade or aortic failure. Is a class 1. Valve preserving surgery, tubular graft if normal size, aortic and no other pathological changes in valve cus, then is also classified as class 1. Replacement of aorta, aortic valve with composite graft, and this comes into class 1. Valve sparing operations with aortic root remodeling, class 2A, and valve preservations and aortic root remodeling in Marfan patient as 2B. So these are recommended by European Society. Now, remember here, what is the basic principle? I'm just going to, from here onwards, just going to scrape through my presentations and slides. The whole purpose is converting type A into type B. That is what your aim is. And for me, I have realized over a period of time, surgery of aortic dissection is management of friable tissue, nothing else. You have to understand that however good job you'll do, all your efforts will be taken away by bleeding. So you need to know how to manage that bleeding. So it's better that you start your surgery with this mindset, that you every stage, everything, anything what you're doing is not going to end up bleeding. Many times we say that baad mein se dekhenge, let us see later on. If it bleeds, I will take an extra stitch. There is nothing called like this in aortic dissection, because once it starts bleeding, it just takes away a couple of hours, just controlling that bleeding. So whatever you do it right at that moment at your first stitch itself. So converting type A into type B is the basic surgical principle, and managing friable tissue is the most important surgical principle of managing or operating on an aortic dissection. So there are various ways how we are going to do. Closing the false lumen is another one what you should remember when you're doing aortic dissections. So there are various ways. I will just try to put it up in further slides. Equally important is anatomy, knowledge of anatomy. Go back to your Gray's Anatomy, pick up this image from there, go through each and every structure in and around, because you are very, very commonly going to injure the recurrent laryngeal nerve, the vagus nerve, because there's just nothing called as anatomy there. Everything is red hot. You just don't know where is what. You are just cutting blindly. You don't know where you are venturing into. So the pre-knowledge about all those things helps us, and that is where apart from minimal invasive, even for aortic surgery, you should do one dissection at least 1 month or at least a quarter in a month. Then only you are able to progress and make what mistakes you have done in the last case will help you to correct into the next case. So surgical interventions here is either you should have, it is all depends upon whether it's an acute or chronic surgery for aneurysm or dissections. So whether you're going to do ventral surgery or bioventral or valve sparing or David surgeries, and whether your involvement of arch is there. So classical elephant trunk, frozen elephant trunk, or hemi-arch. As of my practice, I don't do just ventral in dissection, type A dissections. For me, arch is equally important. The minimum I do for any of my dissection is hemi-arch, because if you end up just doing a ventral and coming out and you're jeopardizing, the whole idea of dissection surgery is take care of your valve, your coronary ostia, and take care of your arch vessels. So just by fixing up your proximal problem of aortic valve or coronary ostia is not going to help. Your dissection should not extend into your the great vessels going to your brain. So you should be 100% sure when you come out of the table that you have not jeopardized the blood flow to the brain. So there has to be no dissection extension in any format into the cerebral vessels. So don't get jealous. There are a lot of women around here. That's what cardiac surgeons are. But then, as I said, it is all about planning a dissection. It is not one-man show. However great surgeon you may be, the lowest possible cadre can spoil the whole surgery. It has happened. It has happened with me. While operating in middle of the surgery, I saw one of the arterial line which had taken into the system had full air into it because she forgot to clamp it, and we had a patient with a stroke the next day morning. So it's about taking to the whole team, and I have realized I was the same thing, and I have an anesthetist, fortunately is my wife here, who said that you need to sit and discuss and tell us what exactly you're going to do, because in your theater, nobody knows what you're planning to do. And that is very true. Then that's where we started picking up. She's not there in this. I kept her out of this picture. So, but then I said that the planning and discussions is very important. The strategy has to be there before we just get into the OT. The anesthetist has to be told what exactly, because if I'm going to take a carotid line as my arterial circuit, then I need to tell them that please do not touch my left side, because I'm going to use my left carotid for cannulation. So you can put your jugulars and anything, whatever venous lines from the right side. So they have to know about all those things, because the minute the patient is on the table, the anesthetist first takes the needle and starts piercing the right side, and it is not they are not able to get it, they jump to the left side and your cannulation site is gone. So a surgeon cannot just enter when the patient is pained and draped. In a dissection, you have to be there around, tell each and every person what exactly is to be done. So the perfusion strategy about the cannulas, about the cardioplegia circuit, about what cannulation you are going to do, temperature strategy has to be told, and then your surgical assistant has to be told about how exactly you are going to go about the dissections, about the cross clamp, you have to tell the other, the perfusionist to keep the glue, the felt, pledgets, everything ready. And of course, the blood bank, which has to be told about blood products. If you have a cell saver, nothing like it. It has saved me a lot of time, because I think that is very important for any unit which is doing aortic surgeries. A cell saver should be there. Blood products like Octaplex has also helped at times to me, where their bleeding could not be stopped. They were in frank coagulopathy because the hours are large. We are cooling the temperature, we are taking hypothermic arrest. And that is the reason that the coagulation is completely at a loss and they bleed like hell. So anesthesia, from their point of view, it's artery line insertions. You have to tell them that please do not venture into my left system or right side, wherever you're going to cannulate your femorals, your radial artery cannulations, that all has to be done. Now remember, there has to be an opposite side, one femoral artery cannulation and one radial artery cannulation for your temperature management, for your pressure management, which is very important for your pressure management. Cerebral protection is very important. You have to make them understand there are a lot of gadgets now available to manage the cerebral oximetry can be taken, can be used during the surgeries, which will help us when we are going for deep hypothermic arrest. Rectal temperature, pharyngeal temperature, bladder temperature, all has to be monitored, and 2D echo always helps you if you have one. So this is cerebral oximetry that you are doing. Perfusionist plan of cannulation. Now remember, it's been a practice at my place that I keep 4 arterial ports ready on hand even before cannulating. So I tell my perfusionist that I need 4 ports ready. The reason is, one is I normally use axillary cannulation, maybe one femoral cannulation, and I keep 2 for my left carotid cannulation if I have done it, and maybe just an extra port for my distal when I finish my distal anastomosis, then I can put up to my graft one more. So the 4 are on table. Whether I use it or don't use it, that assembly is done. That's now standard practice at my place. And then venous cannulation can be femoral vein. That's a much better. And if you think that the dissection is really, really bad, there is a rupture, there is an impending rupture, then I do an axillary cannulation with femoral vein and go on pump. That's how it is. Many times I have always done. Now my temperature strategy, which I'll say that we have to talk about, tell them about the integrate cerebral circulation, the total circulatory arrest which I'm going to need, and at what temperature, and how I'm going to manage our abdominal organ perfusion. Now remember, time just flies in these cases. We just don't know how much of time has passed by the time when we have started doing a circulatory arrest. Suddenly we realize that we have done only half of the anastomosis and we have still not, and we have already crossed our 25, 30, 40 minutes. So in that case, this multi-arterial cannulation helps you to forget about circulatory arrest. So now deep circulatory arrest is now is no more what it is. It used to be. Now there is an integrated cerebral circulation. You can carry on with your abdominal circulations. All those can be continued, and you can cool the temperature only up to 28 degrees. Moderate hypothermia is not all that can be achieved, and safely done the whole procedure. Then you are at free. The time is free with you. Then you can take as much as time to have a nice repair of the whole case and come out with good results still. CPB is traditional. Just tell me whenever I finish my 25 minutes. Cannulation, arterial venous RSPV vent is very important. We have to just think about all such things. This is axillary artery cannulation. There is a video, but I think I'll just scrape it. This is most important arterial cannulation for dissection. You get used to it, and I don't think it is very difficult because it helps you for your integrated cerebral circulation. Now, this is how it is. Quickly, it doesn't take much time. Once you know where to take your incision and how deep do you have to go, just cannulate it. You can do that if the time is not permitting, patient is not stable, just put a small cannula directly into your artery. You don't have to even show a graph that what I had shown. Venous cannulation. This is one more here. It is a common carotid artery cannulation is also I do, because that gives me a safeguard of perfusion with both left and right carotid artery. When I'm doing this, I always see that I always go around my left subclavian because there is always a steal from the left subclavian when you're doing based on left carotid circulation. So this is femoral venous cannulation, cerebral protection. Now, this is the Achilles heel of aortic surgery. Remember that. Cannot take this very lightly. Antegrade cerebral perfusion, you can use axillary artery, left carotid artery. You can directly cannulate the left carotid with a, now you have nice balloon catheters where you can just introduce into the left carotid and continue as when you're doing the circulation. It's very, very simple. You don't have to even sew a graft, but as a practice, I still do a left carotid artery graft and put up for circulation. So because there was one patient which had, I think, circle of Willis was not complete. I based my whole circulation antegrade cerebral perfusion only on axillary artery, and apparently this patient had neurological complication post surgery, and that is the time I started doing a left carotid cannulation also. See that we all know how to go about retrograde cerebral perfusion. Now cannulation is no more what I practice anymore. It's all about antegrade circulation. I picked up this slide because there is always a steal. One case which I had done to left carotid, the whole circulation, because the dissection flap was entering into innominate and into the right carotid. So I had done the whole perfusion through my left carotid. In that case, a lot of blood comes back from your left subclavian through the vertebral arteries into your aorta. There is where it is very important that you snug the left subclavian or clamp it off when you're doing a cerebral perfusion. So important cerebral renal protection by dexamethasone, thiopentyl, ice packing on the head if possible, and CO2 flooding of the operative field. Renal protection by mannitol and furosemide. Temperature strategy, as you know, that deep hypothermic arrest, I keep it now. You can have 14 to 20 degrees cooling before circulation or shutdown. If you want to deep hypothermic arrest, you can get 40 minutes of circulatory arrest there, but no more that is needed because the problem of coagulation is much higher with going to this deep hypothermic arrest. You can always go to moderate hypothermic arrest with 28 degrees and keep an antegrade cerebral circulation. You can also keep an abdominal circulation going on. So these are now surgical aspects. As I said, if the valve is good, you can always do an aortic resuspension. And if the valve is involved and you need to replace that valve, then either it is a root replacement, and otherwise if the valve is good, you can always go for a valve sparing root replacement. Now let's talk about root surgeries in dissection. It is either Bental, valve sparing, that is what we David or Yaku's procedure. And in case of elderly patient, we go for BioBental. Remember that there are various ways to safeguard your dissection segments. You have to see closed, as I said before, that you have to see that the flap has to be closed. That's very, very important. Then otherwise the dissection post-operatively, you'll see your radiologist will say there is a big dissection flap going up and down. So we have to see that the flap is properly closed. There are various ways to close it. This is a Dacron patch. Now I use a Dacron patch outside and a bovine pericardial patch inside, because remember that the least strength is in the endothelium and it just cuts through. So it's very important that you buttress it from inside also and outside. Outside you can very safely use Dacron. I've seen people using Dacron felt inside also, or felt inside also, but I feel that to be too gross. Then I prefer to use bovine pericardium inside. There are various different techniques. So one thing is very important, the knowledge and various technique. You don't know which technique you are going to use for that surgery, but you should remember, or you should know in back of your mind, different ways of solving the problem. One is this sandwich technique for dissections, where people have put a flap inside, a patch inside and patch outside, and then done a run over closure. Then there is something called as, the adventitia itself. I have done this once, but then, it's all diseased tissue. It doesn't give that strength. And then after that, I've stopped it. You can just invert the whole adventitia and make it a double layer just to give it extra strength. But eventually I realized that even both the aorta it just cuts through at times. So you have to give it a strength with a Dacron felt. This is what it is, the telescoping with insertion. You can put your whole graft inside and take a inverted this thing of the adventitia. This is another one I had read, and I've done it once. Inside the do patch flaps, I had put one small thin our Dacron and put a glue inside and then closed it so that the flaps are closed. So these are the various ways which we can think about, when we are in trouble, to see how we can close the thing. Now, dental surgery, remember, keep it as simple, minimum dissection. You don't have to do over dissect. The minute you do over dissections, you are going to end up with bleeding. So need not go below the aortic annulus, just dissect each commissure, ensure good margins of the annulus so you can sew the coronary button. So there is use pledgeted sutures all the time. Don't say that I can go get away without pledged suture. Pledged suture is must in dissection surgeries. There are various ways to put pledged. You can put the pledged when you're doing intra-annular conduit implantation, then you can put the like an aortic valve outside, or you can put it inside the LV, but always a pledgeted sutures. Last case I have done is I have gone put the pledged outside the aorta and come inside the aorta along the annular along the commissure, and putting just I double buttressed it with a pericardium, bovine pericardium also, and that since then I have never suffered. Last few cases we have not been using glue or any sort of blood products or anything for dissection. As I said, the minute you do more and more, you start making your own ways of doing things, and you can just come and fix up things. So this is the pledged inside the OT. Now, as I said, when I am suturing, when I'm going to tie the conduit also down, the suture goes through the conduit and through a pericardium. I take a pericardial strip and put it up. So this helps me to just reverse that pericardial strip and sew it to the native aorta after once the primary conduit is put down and tied, which will give me a double layer so that bleeding is taken care of there by tamponading. So this is how it goes down. So biomental, I just put this slide because we have to make, we don't get a bio conduit or a conduit with a tissue wall. So we have to create one. In that case, remember that a conduit which is more than 3 size minimum or up to 5 bigger size. If you're taking a wall of 23, your conduit should be either 26 or 28. That is what you can take to suture it. There are various ways people do it. I normally first completely run it and suture the whole conduit to my valve so that it gives me a better handling during the surgery. Or you can just put the conduit on top of it, and when you're taking the sutures, you can go through the conduit and through the valve and the conduit at the same time and tie it off. So you can modify it in different ways. I normally do French cuff now, because especially in biodentals, because then next time I have to go in and replace a valve, I don't have to replace the whole conduit. Now, what is French cuff is just keep a small strip of it and sew the strip to the annulus, not the valve. The valve is floating up, the valve is above. So next time when I go in, I just open the conduit and I can just remove the sutures from the valve and replace the valve into that conduit. That is what is the French cuff. And I think I have not got my own redo still, but I am hoping that what has been said, that it will help me to just replace the valve in the next time, because it's a bio valve and naturally is going to degenerate, and we're going to need replacement unless we go for TAVI. David repairs, I'll just tell you that here you have to go below the annulus. The dissection has to be below the annulus because you have to go and put your conduit down, your suspend. So you know the different type of David modifications, David 1 to David 5, which is now a standard, and either it is implantation or it is a remodeling. Now that itself says when we talk about implantation, the valve is inside the conduit, the whole tube just goes down below the annulus and it is fixed there with loosely, and then the valve is sewed inside. I'll show it in this thing, next pictures. So this is where the dissection goes in. The level of dissection has to be below the annulus. And I won't show you any videos. There are videos in it, but then that will take a long time. So this is how the valve is sewed inside the conduit. You have to go with a continuous, you can use 5/0 or you can use 6/0, and the whole commissure along the commissural line is sutured inside the thing, and then you can suspend the valve inside the conduit. That's what is the David's repair now. And this is how it looks after implanting into the conduit. You don't have to really worry about bleeding in such cases, but when you're sewing it, see that you be careful that you don't jump so much and cause dog ears inside, because that is what you cannot fix it once you are off, when you remove the clamp or you can't see it from outside. So whatever you do, 1 layer, 2 layer, whatever you need to do it, you have to do it now and see that it is properly fixed. This is Yakub, which is normally implant remodeling. Just the sinuses, the tube is cut into 3 tongs and then they are put into, and with the coronary implantation. I have done Cabrol also, because once the dissection had gone into left coronary ostium also, as well as into right coronary. So I just put up a ring Gore-Tex graft and I sutured both the ring to left and right first, and then made a big hole inside and put it into my main conduit. That's one surgery that I've done. So you have to keep on innovating. That's what I wanted to say that. So this is how I had done. In one of the case, left and right coronaries attached, not the exactly the way it is done. If the coronaries are not properly coming, the buttons are not coming properly, then you can just put small tubes and then put them onto conduit. You can just bring them anterior and put them on the conduit. So the way how to mark a site of coronaries, right? Normally the right coronary artery, you just fill up the heart a little bit and see where exactly it is coming, mark it with a marker pen, and then you can just open. Don't have to make a big hole. You don't have to use a big cautery. Now, earlier I used to make a big hole. Now I just make a very small cut, just 1 fold, and then I sew that. Very important when you're anastomosing a coronary is that see that you don't go far away, because the tissue is disease. So it will always get through. The most strongest part of coronary ostium is at the ostium itself. So your suturing has to happen, and literally that ostium has to fit into your conduit. And I'll tell you that it doesn't bleed, because that's the strongest part of the ostium. Unless it is dissected, then you have to see that you give a nice patch around outside, either use a pericardium or use a Dacron felt. I'm not showing any videos. So this is another thing I had done. Distal perfusion. Distal perfusion, I use a Foley's catheter. I didn't have a big catheter. I just put it and right. A lot of blood keeps on coming when your left carotid is flowing and filling through the spinal and into the aorta. And it just doesn't allow you to complete your distal circulation unless you are just completely at hypothermic arrest and no flow. But if you want to continue with the flow, then you just put up a Foley's catheter inside and finish off your distal anastomosis. So distal aorta, remember that you have to manage your proximal intimal tear. See where exactly it is. See, that's the reason I said when it comes to dissection, it's never only just Bentol. I always minimum do a hemiarch. I go or implant all the vessels here. This is hemiarch, as I said. Otherwise, I just implant. The whole 3 cerebral vessels can be implanted as an island, a big Carroll splash type of a thing on the graft, or you can use now Sienna graft, where they are with the individual conduits, which you can suture to each and every vessel. So in dissection, double buttress with felt pericardium is very important. The other thing what you remember is when you're going for a distal, your preparation of the distal cuff has to be perfect, because that is one place. Once you remove your clamp, you are just not able to see anything unless you go back, cool back again, arrest the patient and do it. So for that, as I said, take extra time, no problem. And keeping a moderate hypothermia with an organ perfusion, continuous organ perfusion, you can take ample time, maybe an hour or so, even if you need it, but do it nicely and do it once. These are the different balloons which are available. Dr. Bartholomew, he had come to demonstrate one frozen elephant trunk at my place. He had brought some balloons. So that is available into the market now. You can do individual carotid or subclave, and every artery can be cannulated. As I said, you have to have extra arterial port so that your perfusion can continue while you are performing the surgery. This is the Sienna graph. This is how I've done it. This is, do you think it will play? Frozen elephant trunk I wanted to show. No. So in short, I think we are just nearing end, and I think I've taken enough time. Okay, things gone. So in conclusion, what I would say that I'm not covering type B or dissections, what exactly TWAR and all those things. I think for this time, this much is enough. Maybe Dr. Agarwal will call me again. I'll have a better videos to be to show you all. I think it's okay. I think we have told it. So the question is now in about aortic dissection. First of all, what most important is you have to know the disease, and you have to have certain experience, experienced person around you to take you through for a couple of cases. Very important. And as you do more and more, like any other surgery, this becomes a routine surgery for the whole center. And as Dr. Bashi, as you know, that they are the one center in this country who is doing maximum aortic surgery, and they have come with their own shortcomings initially in their initial time. So is our unit. But today we are so confident, my whole team is confident that they know what exactly to be done, and which is one of the most important aspects of developing an aortic surgical department. It's not about only aortic valve. This is a completely different, it is a unit, it's a specialty in itself. And once you get a hang of it, I don't think it's any difficult surgery. Thank you. I know there will be some queries, questions I can.
So once you convert this into type B, so what is the follow-up?
So every 6 months, the first follow-up is after the initial time is for 6 months, I come and get him assessed. That CT scan itself helps me to have a primary, what repair I have done exactly. I don't go and do a CT scan immediately. After 6 months, I do a first follow-up CT. And based on that, I'll start following up every year. That's more than enough, I suppose. So I have a couple of patients which I have done before, and last 3 years I've been following up for distal, and they are absolutely stable. Most of the time, there is a fair amount of remodeling. We don't need to do anything. But in case if we need to do anything, we can always go in for TWAR now, because that option is always available. And frozen elephant trunk or Sienna graft both help us for better landing of the stents.
So how many Sienna grafts? Do you always use Sienna grafts or hemiarch? We can do with hemiarch.
We can do with hemiarch. It's not necessary. If you know that your great vessels to the brain going are not touched, they are not involved into that flap, then you can safely take an island and just use our single graft. I use a single graft, literally. There are grafts which are with a little nice curvature. It gives me a nice flow to that whole thing without causing any kinking anywhere. And I just put it as an island graft, because then I don't have any time restraint, because all my coronary carotids are flowing. My cerebral perfusion is taken care of. So I can take my sweet time and just do the whole grafting. So that's the reason I say that I normally put up a left carotid graft and cannulate it, and my axillary. So I can just clamp all my 3 great vessels and finish off my procedure. And in case if the dissection is going into the carotids or innominate or subclavian, then I use Sienna graft.
And when do you choose to give femoral perfusion to?
But femoral perfusion when I'm finished with my whole distal anastomosis, okay, or I just put up a balloon and I see that I'm taking a little more time with a hypothermic arrest, then I start my femoral perfusion and block that backflow of the blood with a Foley's catheter. So my abdominal is taken care of. My renals are taken care of. there is always a danger of retrograde flap raising up. But then, as I said, that once your flaps are opened up and there are multiple tears, so it is well taken care of.
Nowadays, we have a lot of cases where there is no aortic regurgitation.
Yeah.
It's only ascending aorta dissection.
Yes,
And we have done such patients by replacing only ascending aorta replacement.
that's
Doing nothing. And they are doing very well. Most of those are basically uncontrolled young hypertensives. Those patients are in CIF and they just present emergency with the ascending aorta dissection only.
so only thing what you need to remember here is that most of them are Marfan's.
No. That is what I tell you, sir.
Dissection cases.
That is what I tell you, sir. Our most of the patients, in a Marfan, there is no point in preserving anything.
Yeah.
That is what I believe. In a Marfan, you go for a complete benda because it requires a replacement. What I'm telling that is our experience, we have 25 patients over 3 years. And we have observed them severely, their valve, everything remains normal. Initially, when they present with the dissection, then severe AR, ascending aorta dissection, because of dissection, intraoperatively, we examine the valve and we just replace only ascending aorta and they are doing very well.
Very. So that slide one which was there, just rerun it and resuspend. The reason for AR, you have to understand this. Then the minute the flap goes inside the commissures, inside the sinuses, it deforms the aortic valve. And the minute you fix this and the blood is no more going inside, this valve becomes competent. So not necessary if you see an AR on an echo preoperatively means you are going to go ahead and do a Bentall surgery. Keep an option open, analyze the valve when you opened it up, you fill it up, you see you can very well assess this valve is fairly good. You suture that whole thing, fill up the valve and see there is no regurg. Many times we have just come out with just putting up an ascending aorta graph. I have those videos also.
Second subject, often we get second subject, that is those who are patient AS, AR. Including AS, chronic AR, they present to us with the ascending aorta dissection. Usually in the acute condition. AS, AR, they are in the forum and present to with ascending aorta replacement. In these such cases, we do only beat operation. Just aortic valve replacement, we can remove the disease portion of ascending aorta, basically converting type A and the ascending aorta replacement to replace. So that beat operation follow-up is also very good, sir. And patients also are doing very well over a long term because ascending aortic valve is replaced, ascending aorta is replaced. The most important thing, normally we don't dissect and reimplant.
Yeah.
So the bleeding portion, excess CVV time, everything is avoided.
So what exactly is what we talked about earlier? It's a wheat procedure.
That procedure is really helping us to salvage many of the patients.
Now, last wheat procedure I did, I think I burned my fingers there. Okay, it's not that every patient will be. The AS patients or these patients, aorta is very, very thin, paper thin. And you end up, bleeding at some point or the other. And we have seen that because the tissues are different now, the stress on those tissues can be different and resulting into tear. So you have to see that you really, really reinforce. Now, there is a limit of reinforcing because your felt or your strip cannot go below the sinotubular junction. So you have to be careful there. And if it is high up, the problem is of leaving diseased tissue there. It can cause bleeding. So this is just, as I said, we have to keep on innovating. You can think at that time, what is the best thing for that patient and do the best.
Okay, I really enjoyed the talk. I just want to ask you, including you said that we have done a great number of cases which was just the replacement of the ascending aorta. So in those cases, what were your permission what did you candidate and what did you do?
Remember, I'll give my point then. Remember, every dissection case, your primary preparation has to be the same. You go prepared because later on, if you decide to do something else, you want to do something else, then starting doing those other things becomes a problem. It will take 10-15 minutes. You can cannulate your left carotid. You can put up your axillary cannulation. You keep these basic things the same. The minute you start I may come out with only a wheat procedure and I will do this, and you don't come out with a wheat procedure, you'll be in trouble. So that's the reason I don't change my cannulation policy at all, irrespective what I'm going to do. It's good. If I just do a ascending aorta replacement and come out, my timing will be less. I don't need cerebral perfusion and I don't need to do anything more. I can just decannulate at the end of the surgery. So you'll have a problem when the dissection flap has gone into innominate. Then you have to start thinking about your strategy again. Or I had that problem. Auxiliary cannulation is a gold standard. I think everybody should go in for auxiliary cannulation. You can go for left carotid cannulation also. Yeah. So it's just question of numbers. Even if you keep at 32, you will see that it has reached to 28. That doesn't mean you have cooled it. So safely keep it at 28. You don't have to, you have to tell your perfusionist, don't let it go below 28. That is what you have to tell the perfusionist. Then there is no control between 32 and 28. Remember that on table.
Just a word from my side.
Yes.
I mean, nothing succeeds like success. Whatever you do, you have to defend the patient. The cerebral protection that you were talking, this is for the junior staff, that they should know that the circle of Willis is incomplete at 81 to 89%. It is not complete in 80%. It's incomplete. That is very important for you to remember. And the second point is that what you are saying about the bleeding. Remember, the media is the weakest thing. The endothelium is the weakest thing. All the strength comes from the adventitious. You have to be very sure, otherwise whatever you have done will go down the drain and you will never be able to salvage it.
There were certain two slides, I think it didn't move forward. How to, when there is so much of bleeding, I don't know, I have never done it. You can just connect your right atrium to that wrap around thing, but I don't know whether you have done it before. I just seen this when I was reading, connecting so that the blood from there comes back into RA, but practically I don't know whether it works. For me, cell saver works much better. I put my cell saver thing there, it comes and given back blood to the patient.
Those days when they were not able to do all this cell saving and all, but now I don't think we should do that. Don't do this surgery.
Yes, that's the reason I said that whatever you do primarily at the time of surgery. Take all possible precaution, you will never regret. The minute you are in a haste, the timing is what makes you, hasteful. Like, I mean, you are trying to run with the time, and antegrade cerebral perfusion, abdominal perfusion has just changed that way of doing dissections. You have ample amount of time. You do a good job and come out, your patient will still go home.
Thank you very much. Dr. Hanbajia for a very nice presentation and a very good presentation afterwards.
This question is for Dr. C.S. Heramat. He is at present secretary of our IACTS, Indian Association of Cardiac Surgeons. He is chief surgeon at Sri Satya Sai Institute of Higher Medical Sciences, Whitefield, Bangalore. And he is going to talk on IACTS and innovations in India efforts and leaders. He has been very successfully conducting the master class for MCH and DMB residents from the IACTS forum. And welcome Dr. C.S. Heramat, please.
डाउनलोड मत कर।
जी सर,
डाउनलोड किया
नहीं डाउनलोड नहीं किया।
ये मुझे बड़ा करो ना,
हाँ, बड़ा कर लीजिए।
आ जाएगा ना वो। Good morning. Doubtless, let me thank Dr. Agarwal and his team for inviting me here. Well, he has given me quite a unique topic this time. I had to take some time to prepare these slides. And I think the slide presentation is a different format. तो मुझे ही करो इधर मेन प्लान उधर मेन स्क्रीन का। Yeah. So just to mention how the IACTS came into being, the origin of the Association of Thoracic and Cardiovascular Surgeons can be traced back related to its development in thoracic surgery from Christian Medical College. I think Dr. Shukla is here. Yes, it was the place where the association took its birth, and that's where Dr. Dept was there, and he organized and founded the first full-fledged department in the thoracic of cardiac surgery in the late 40s. Next, in 1954, Nagpur session of Association of Surgeons of India, they first formatted and they had a first session of thoracic surgery there. Subsequently, 15 members in the beginning, that is Dr. Dept was unanimously elected as the first president. There were no elections those days. Followed by Dr. A.K. Basu as its first secretary. Dr. Dept functioned as president for 4 years and was succeeded by Dr. S.S. Anand. Today, the president's role is for 1 year. Even though they are elected as the vice president, they spent 5 years in the association. But those days, it was 4 years. And later on, succeeded by Dr. S.S. Anand, Dr. Sen, Dr. A.K. Basu. Dr. Basu then functioned as a secretary for 4 years, and later on succeeded by Dr. N. Gopinath for the Godrej Karai orations. And even Godrej Karai was there in the part of the team, Dr. G.B. Parulkar and Solomon Victor and others. Unfortunately, most of them are not there today. In the next few years, as cardiac surgery began to grow and take a major share of the annual meetings, the Association of Surgeons was established way back in 1960. In 1972, Dr. Sujay Roy and Dr. Gopinath brought cardiologists and cardiac surgeons together, and the first meeting was organized in All India Institute of Medical Sciences, New Delhi. The name was changed in 1982, that from Thoracic Surgeons of the Association of India to Association of Thoracic and Cardiovascular Surgeons of India. It is CVSI. A charitable trust was formed in the year 1991, The first independent annual conference of ATCVCI held at Madras in the year 1988 gave impetus to the formation of new independent society. The Indian Association of Cardiovascular Surgeons, ICTS, as we stand today, was registered in Bombay under the Societies of Act 1860 and Bombay Public Trust Act 1950. Today, with over 2,500 cardiothoracic vascular surgeons in its fold, ICTS continues to function with increasing vigor and enthusiasm. We'll meet the current ICTCC members as we have the President Secretary, all are there in our ICTS websites, and the EC members. Well, the calendar is filled with different events, continuing medical education programs and conferences throughout the year. These events provide opportunities for not just learning and sharing knowledge, but also networking regardless of age and experience. We have the ICTS Con conducted every year in the month of February, either second or third week. Normally it's conducted third week, but depending on the cities and the environment there, we do happen it either in second or third week of February. And it's an academic section, clinical discussions, industry collaborations, interactions, which are there, which is the latest, which is the hallmark of our association. The ICTS Techno-College CME, an opportunity for residents to gain practice, insights, hands-on training, and learn from experienced minds in CTVS with newer advances. ICTS Cardiac Midterm CME and Midterm GBM, what we call it as. We have a annual general body meeting in the association in the month of February always. A continuing medical education program focused on cardiac surgery and meet up to abreast of the happenings of the association. The ICTS Thoracic CME, an exclusive event to expose the concepts and advances in thoracic surgery. Normally it's conducted in the month of November. Techno College conducted in the month of May, and Midterm GME conducted in the month of September, August or September. We added another one called ICTS Core last 9 years, a program that has been run by the CTVS academicians and clinicians to help students to prepare for the DNB practical examinations. It is one of the unique kind where I took a lead way back in our institute, and anybody who attends this program, the pass rate of that candidate is almost 99 to 100%. That's what the output is. And it's a 2 days program, quite tight scheduled, and it's been continued through the association. And in fact, we do have our notes for this exclusive notes has been made every year. We update those notes on each topics, and invariably the students happen to go through that. Apart from that, we have exclusive academic programs for our members of the association, an opportunity for young surgeons to work closely with and learn new skills and techniques from his experts in coronary surgery, congenital surgery, thoracic surgery, valvular surgery, video assisted VAD surgery. These are the fellowships running currently today by the association. They're certified by the association. Of course, another recently I happened to introduce way back in this year itself, that is a certificate course in critical care echocardiography. It's conducted in collaboration with 3 associations, the Indian College of Cardiac Anesthesiology, Indian College of Echocardiography, and our ICTS. So all 3 come on board, and at present we have registered 170 students. There are many general anesthetists who want to focus only on echocardiography, even they are included. Anesthesia per se, they have their own courses in cardiac echocardiography. But apart from that, some who want, without being a cardiac anesthetist, they would like to learn for their day-to-day routine. We have MD physicians who have registered, and we have our CTVS surgeons who have registered for this program. Every Sunday, there's an online program running from 9 to 10 a.m. Sunday breakfast session, where who is who in India among cardiac anesthetists and cardiac surgeons, they sit on board and help them to train. This is only an online training. They have to maintain a regular logbook, a curriculum. So many cases of transthoracic and transesophageal echo, practical logbook is maintained, and they have to attend physically at least 2 workshops. We have in the month of August conducted at Bangalore and workshop with their compulsory registration, and they will be having hands-on workshop also during those days. And they will be having an exit examination conducted in, at present 2 cities have been chosen. One is Bangalore and another is in Ahmedabad. Subsequently, we may increase wherever the students, number of students which increase also, we will plan to increase the number of examination centers, and certification will be given by, duly signed by all these 3 associations. I'm planning to have a collaboration with Rajiv Gandhi University also in Karnataka, which the papers are in progress. Coming to online technology to keep up with pace, as I was having a discussion, the IJTVS is online. As we know, it's a PubMed Index journal of the IJTVS, and members can log in with their unique ID. Self-serve memberships, medical and non-medical professionals can apply for memberships. That's the associate membership on the IST website. Everything is digitalized. Even digitalized IDs have been issued and digitalized certificates have been issued in the association. Of course, IST's elections, what is the progress? It's fully online from the year 2021. And ISTS is present on Facebook, Twitter, YouTube, LinkedIn, and Instagram social media. We are already on place. Other associated initiatives, as we mentioned, masterclass series. Almost 242 masterclasses were conducted during the COVID times. Well appreciated. 27 countries participated with more than around 60 to 70,000 participation was the number. We were conducting almost 4 classes in a day and gradually tapered down. And these master classes, we have edited the videos. Initially, we had a plan of action to be published through Springer on our journals. It took quite some time, and finally Springer were unable to take up the entire load. They had their own concerns, and of course, copyright issues and all, they had that concerns. And we happened to discuss with our chief editor, and even the IJTCVS to publish, because it is Springer related, it was a challenge for us. I have edited all the videos. And now finally we came to a format wherein it will be released to the members on our website itself. It's almost about 2,640 hours of video presentation, which had a Herculean task to edit. And I requested few of the industries to help us in collaborating in meeting the expenses of the editions, and subsequently it will be uploaded on our own website. To load on the website also, it's a challenge wherein the amount of space consumed is more. And a proposal put in front of the EC for the additional space to be consumed on the Amazon services, what we are functioning at. Coming to e-journals, subscription of 7 international journals was rolled out 2 years back, and there are more than at present around 300 plus members who are actively participating in this. It's per member. If you subscribe these journals, it will cost you around 4.5 lakhs per member per year. So association in collaboration with LCV team, I took an initiative and we have reduced the cost to 5,150 rupees per year for these 7 journals, and members are actively utilizing it. It's an online journal. Coming to the benevolent fund, what association took an initiative, it has been happening for the last almost 20 years plus, which was not happening. And finally, last year we happened to release a benevolent fund. It's a corpus that offers to one-time support to the family of the deceased ISTS members. That's where we look at, and depending on the requirement, maximum up to 5 lakh rupees has been sanctioned by the association to those deceased members. Mentorship at a doorstep, which was introduced this academic year. We will be, it's in on process, and already 2 applications are there. Next week, they are going to start their program. So ISTS has taken initiative, like so many questions we had asked about whether it's an aortic valve repair or arch surgeries or aneurysm surgeries. If we are unable to perform, a mentor from the association is chosen, and you need to write an application to the secretary's desk, wherein they will come down and help you to train of doing the surgeries. Of course, many clauses and are there wherein you need to fill a form. There's a Google form which has been created and circulated almost 3 times. I have received till now around 8 applications, which will be attended to. Apart from this, ISTS projects, yes, ISTS National Database Registry, which we happened. It was a big challenge for me to start a database registry. If you ask me today, we do not have our own guidelines. That's what our discussion was going on. We always follow UK and US. We have read textbooks written by them because we don't have our own research articles. When we can produce all this, when we have our own database. This is a huge initiative taken by the association. It is coming up in a bigger way slowly. And we happened to start initially I planned for our institute. Why not for the entire country? 12 nodal centers in the country were recognized, and a database manager was identified, and we got it inaugurated way back in the year 2020 by then the Health Minister of Government of India, Dr. Harshvardhan. He inaugurated the database, and last 2.5 years, we train the institutes, the assistants, physician assistants, or perfusionists, or the residents. Training is happening every day almost, and we have trained almost close to around 90 plus physician assistants or perfusionists or students across the country in these 12 nodal centers till date. And initially, first 2 years, we initially planned only for the institutes to see how it runs. The database formation also was quite challenging. Initially, I thought replicating the STS database, we happened to take that and plan on an Indian platform. It was almost 67 pages. And our surgeons refused to fill 67 pages, which takes hours together. There are different data operators in US and UK, but that was not to be implemented here. The template formation, that was challenging. template we happen to form. I sat and studied 7 templates of different countries, whether it is USA, UK, Singapore, Malaysia, Thailand. I happened to study their templates and formally formed the Indian template, which is 6 to 7 pages for adult and congenital heart disease. Templates for aortic surgery is on process. Template for thoracic surgery is on process. So templates were formed for adult and congenital of about 6 to 7 pages. Takes exactly 3 to 4 minutes to attend. It is mobile friendly, laptop friendly, system friendly. Anywhere as the patient is putting dressing, as the sisters are putting dressing, the resident or assistant can fill in their mobile. Each person will be given a separate email ID. They will be trained how to enter data. Data at present, we are using Redcap platform, which is one of the Australian-based data platform. We are using that, and we are using Amazon cloud services on monthly rental basis to store our data. The aim is to come up with our own data ICT servers, which I am already working on that. So at present, in last 2.5 years, we have collected more than 21,000 plus data. We have formed ICT's database committee. Now, this year onwards, 23 onwards, we have enrolled individuals also who are attached to institutes wherein to fill up their data. They are also coming up. I would encourage many more people to come down. It's a very simple procedure. On the website you visit, you can always register your name. The ICT database manager will immediately call you for how to progress. We have made a MOU so that data is very sensitive issue. All in institute face challenges when they had shared the data, and also we were quite clear on how we go about. We have a legal advisor on board so that that MOU is signed, and then we go forward with that. Another program initiative was World Heart Day, the ICT's outreach program. It's mainly educating the public. Many more initiatives are taken under this program. It was inaugurated in last year on World Heart Day, September 29. Many events were conducted across the country, wherein even basic life support training, BLS training were given to a number of members, and this will be taken in a larger way to the association shortly. Yet challenges are plenty. One, limited, what are the challenges I am facing? Limited innovations, little or no understanding of challenges within the CTVS. Scarcity of homographs, growing cardiovascular disease in India. For your kind information, the current statistics, every minute 4 Indians are dying because of cardiovascular diseases. That's the current statistics today. And children born, every 100 children born, 1.4 is the rate. That is around 1.4 child is born with the heart disease. So in the next 5 years, it is going to increase by 5-fold. That is every 100 children born, you have 10 children being with congenital heart disease. Where are we standing today? And how many are affording treatment in these 100 children is only 20%. Remaining 80% are dying like houseflies, if you ask me. That is the current statistic in the country, what it is facing. I worked a lot in that. I had certain meetings with the government of Karnataka and also government of India also, how we can go forward. I have my plans, how we are going forward, that I will be sharing with you shortly. Absence of medical leader presence from CTVS, that's one. Lack of skill-based models and leadership. That's another thing, skill-based learning program. We have Dr. Hamdullah, the president of the skill-based training program, which took an initiative and working in collaboration with the ICTS, how we can take it forward and practically how students can be implemented. Fewer takers of CTVS over the years. If you ask me, 80 to 90% of the seats in NEET examinations are going vacant. Who is the reason for this? In fact, if you ask me, we are the reasons for this. I can put forth like that straight away because we fail to train our youngsters. And that's where I'm looking at. And this is coming up in a major way. And definitely in the next 3 years, we will make a revolution to see that the CTVS takers increase by default. That's where I've aimed at. And I'm already working on it. Apart from this, the aging workforce, we have our senior faculty, definitely, who all the masters are getting old. Somewhere down the line, we need to have the younger masters. And that also will be in place shortly. The solution, what is the solution for this? That was a center of excellence which I had planned, and this has been named as KSR HB, Center of Advanced Surgical Excellence and Research and Homograph Bank. If you ask me, there are only 7 homograph banks in the country. Even a state like Maharashtra, the financial capital of the country, failed to have a homograph bank. Now, why do we require a homograph bank? Yes, makes a huge difference for a child. We can't replace a valve, we can't replace a conduit, and the number of surgeries required in a child are plenty. It's not that doing one surgery ends up him for a lifetime. He undergoes 3 to 4 major surgeries. Elderly makes a huge difference. Younger patients also, where homographs are required, makes a huge difference. And homograph banks, according to the Government of India Transplant Act 1994, should be provided free of cost. Unfortunately, that doesn't happen in our country. Because the cost required in maintenance of homograph itself is there. Even a country like Australia has got only 3 homograph banks. Recently, the director of Australia Homograph Bank spent 1 week in our institute, and there they charge 4.5 lakhs per valve, homograph valve. And our country ends up spending 40 to 60,000 per valve. Many can't afford, and even the demand and the availability ratio is huge difference is there. And that requires education. So many heart transplants are coming up in picture. Our own students, our own faculty go up abroad, getting trained themselves in heart transplants and heart-related surgery, spending about 6 to 8 lakhs. Everybody can't afford that. So how can that training be encouraged in our own institute, under the association of ICTS has to be taken a lead. Now, in this case, RSB, what all are we are looking at? One is a first free homograph bank for the world, which I am planning it, and it's already work is in progress, and it's a huge project by itself, which together we are working on towards it. And a headquarters for the ICTS database, which we are hosting at the same plan. And another thing is multiple innovations, cafes and labs, wire skill training programs where clinical research can be there in collaboration with the other associations which are coming up. We are working on those guidelines also. Core Skills Center Foundation, that's all where I am working on, where it's whether auditorium, library, online journal centers, or ICTS museum, where today's youngsters do not know who is who. 70 years back, the association had done so much contributions. If you don't know who our mentors, it's a shame on the students also, but not knowing our mentors. We need to know who is who and having their own museums. Wet labs and hands-on training, skill-based cardiac surgical dissections, CPRs, CPR modules, and even morphology demonstrations and several courses, surgery, resources for clinical practice, infrastructure, administrative, legal, and scientific activities are all coming planned in this Center of Excellence. We have a separate executive committee for that, which has been formed. A bylaws has been initiated. All members can join that, and each person will be given certain roles to play. It's not just sitting on the chairs. Each person will be related role, and everybody is accountable. That's where we are looking at. These are the few emergency members we have charted out. Many more will be added shortly, and each person will be on the advisory board. Who is who in the country will be looked into. Apart from that, as I mentioned, I have a few names mentioned as of now. There is still in the process. The bylaws are in process of founding it, working on this. And how does it fund? It's a huge project of 350 crores. So how do I fund is a big question mark by itself. But anyway, the initiation has been started, and we immediately fund by the ICTC, donations from members. It's ATG benefit. I got recently certified by the CSR funding also. I applied for the international funding also, and all these things are in place. The proposed campus land has been identified close to Bangalore. Last 4 years, I've been working on this project, and initially I tried a free land from the government of India, Karnataka, which I had my own challenges. And finally, things are in place. Land has been identified. A token advance amount has been handed over, and followed by that, we are looking it for additional funds for the progress of this project. It's a 5-acre land, and structure design has already put in place. And as we grow in the next, by the next general body meeting, I will have something to present solid in front of the association general body members. Dear friends, investing towards a better collective future and making every heartbeat count is the aim. And that's where I'm aiming at towards the association. I hope I require everybody's cooperation. There are many leaders sitting here, and I think many more to come in and join. So I see that every person leaves behind a legacy in their cardiovascular field. Thank you so much. I'm happy to answer any questions, sir.
It's a big challenge.
Yes, sir.
I did have a hospital where I was staying, it was still functional at that time. The biggest challenge is procuring, and because it has a lot of legality, because we have to take the heart and take the consent. It's as good as taking a consent for organ donation. Secondly, the expense that we have to bear for maintaining it, and then, as you said, that we have to give it free of cost. Till we can't sell it or charge it in our country.
Yes.
I think that was the biggest reason for failure of homograph bank in Mumbai. We need to, basically find out ways, at least try to get this homograph thing so that we generate at least some revenue so we can continue functioning. So that needs also to be addressed.
Yes. Yeah, Dr. Suklap.
I think you work about 28 hours a day, with all the things going on. It's very good. I've just got a small request for you. See, with the time limits for all the registrars and the different students, the score program does a very good job, wonderful job. My sincere request for you to make it Friday, Saturday, and Sunday.
Sir, they expect me to teach the entire CTVS in those 2 days. It's very challenging.
No, 3 days, sir, please. Then
Yes,
I
sir.
really enjoy the program and therefore I would love to be there from the first to the last minute.
Yeah, you are always a faculty for the last 9 years. It's one, they all contribute voluntarily, sir. That's
Oh,
where
what
it
is
is. We took this initiative when Dr. Hamdullah was the secretary. At that time, during his term only, we had planned this.
If you make it for 3 days, Friday, Saturday, Sunday, please look into it.
Yes, sir. Definitely, I'll put forth this proposal, sir, in the upcoming meeting, and definitely I'll take it forward, sir. Yes, it's done. Sir. It was requested by many residents also. I had challenges, but I will definitely take it forward. Sir.
I think there is a sea change in the way ICTS is functioning now.
Yes.
For good, I think we can appreciate the fair amount of efforts that we put by Dr. Hiremat. And I know that with being a secretary of that treasurer, how much of bringing everybody on the same platform and getting things moving is a Herculean task. And he is facing it. So I think that's what exactly you said. He works for 28 hours a day. Yeah, he generates 4 hours per day. So I think we are all there with you, Hiremat. I think this is need of the hour.
Yes.
If this cardiovascular plastic surgery faculty has to sustain and grow.
Yes. Have plans to attend the medical colleges also, sir, on board, wherein the BLS training programs all have been planned so that they will be educated. Sky is the limit to grow in cardiac surgery. And unfortunately, people are not well educated. They get discouraged. Recently, people come down. Medical students, about 6 people come down before going for the interview. They come spend time with me. They are interested because of discouragement for the surroundings. They came to ask me, should I join cardiac surgery? Especially girls are taking cardiac surgery off late. And I encourage them, what is the scope and all, and they are coming down, sir. So I think we will make a change, sir. That's where I'm heading towards. Let's see.
I got this topic and I requested Dr. Hiremat to come and present it in front of the audience. Was that I attended 3 or 4 ICTS conferences in the last 4 or 5 years. And then I realized that even in GBM, we did not have a chance to show what he has been doing and what changes are possible and they are coming. Like database itself, he has put in a lot of effort, but very few people know about it. And then even on the website, most of us don't go through it regularly, only go to look at our own specific thing and then log out. So I thought that this will be a good initiative, and I would request you that in every ISCPS meeting, you should have a lecture like this about the ISCPS, how it is growing, and what all can be added to this.
Yes. Sir, one more few things I would like to update is that the ICTS has taken initiative. I identified a CEO for the association, who is a master brain himself, and I will be presenting him in the month of in the general body meeting. That's number one. Recently, I had a meeting with the IIT team Madras, where how technology can be implemented at the artificial intelligence. Sir, there is something called as artificial intelligence touch-based. There's a professor. I had almost a 2 hours meeting with him, and I am put him as an honorary consultant for our association. I'm trying to get IT technology professors on board as honorary consultants. That makes a huge difference how technology can be implemented. If you want to do a breathing art surgery, I'm creating a module of breathing art surgery when he gets touch feel also in using artificial intelligence. That's where we have planned in this center of excellence also. Including I'm planning to implement a robot also. And Sudhi Srivastava, Hiremat, for your functionality, I will donate a free robot. That's what he has promised. So let's see how it goes. Let us make a difference even for minimal access training. The hands-on training should give a virtual feel. That touch-based feeling is where artificial intelligence is playing a role, and even that is planning to get implemented. So when students are encouraged this, we can do 100 of them on the lab in these simulators, and we can have tie-up with the various institutes across the country, where this becomes a hands-on training on practical aspects before you touch a heart or direct heart there. So that's where it makes a huge difference, and that training definitely takes CTVS course ahead, sir. Thank you, sir. Thank you.
Please, we come to the end of this issue. Now, what is the best?
With this, we come to the close of this 1.5 day CME plus half day Ozaki workshop. And I can see that we had a good discussion and the topics were wonderfully presented by all the speakers. And I thank everyone who has attended this conference in any capacity to take out time from their busy schedule and contribute to this CME. Thank you, everyone. Thank you.